कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Myself, Dr. Madhavi Patwardhan, President, IMA Sangli, on behalf of the Executive Committee and all our members, welcome all of you to today's webinar. I would especially like to welcome our speakers today, Dr. Rahul Pandit from Mumbai, Dr. Jyoti Chidgupkar from Solapur, Dr. Vinayak Patki from Miraj, and our own member, Dr. Anand Malani. I would also like to welcome Dr. Pankaj, Palange, and Dr. Geetanjali Gupte, who will be coordinating the session today. I also welcome Dr. Sharad Gadge, who is observer on behalf of MMC. Today, we are privileged to have speakers of national and international reputation, and I'm extremely grateful to all the speakers for sparing their valuable time from their busy schedule to guide us about the appropriateness of antimicrobial use. We are extremely happy to see the overwhelming response for our webinar. More than 1,300 delegates have registered, and they are from all over India. This huge response, I think, is because of two reasons. One is because of the eminent and renowned faculty, and the second is because antimicrobials are drugs which are used by all doctors from all specialties and all branches of medicine. So we also see that there are rapidly changing patterns in the type of infections, then the advent of newer antibiotics and the issues like their side effects, drug interaction, and all other things. Because of this, many a times we are in a dilemma about which antibiotic to use and how. So today we have a golden opportunity to get all our answers from experts in this field. I would like to inform you that this webinar will soon be broadcasted on our YouTube channel, IMA Sangli Academics YouTube channel, and you can also see our earlier webinars which had already also interesting topics. So I once again welcome you all, and we all hope that this 2022 will be a better and a wonderful year for all of us. I will once again welcome all of you. I thank all of you for joining, and I will stop after chanting a small prayer, seeking the blessings of Almighty for all of us. This is a universal prayer coined by Sadhguru Vamanrao Pai. O God, bless all with health and wealth. Bless all with money and harmony. O God, bless all with peace and bliss. O God, bless all with peace and bliss and your wisdom. Thank you. Thank you. With this, I stop and I will hand over the proceedings to Dr. Pankaj Palange for further coordination. Thank you.
Hello everyone. Myself, Dr. Mrs. Pankaj Palange. I am working as a consulting physician in Sangli and also working as a professor in Bharati Medical College and Hospital, Sangli. I welcome all of you for today's CME. I welcome all our guest speakers and delegates. Today's CME is on awareness of antibiotic usage and appropriate usage. All of us are aware of the use of antimicrobials. Daily in our routine practice, we are seeing emergence of newer and newer infections. Antimicrobial agents are required to overcome that infectious agents, but If these antimicrobial agents are not used judiciously in our routine practice, we can face lot many problems like inadequate doses. If they are used for some infection, that can lead to incomplete cure of that infection, leading to further complications by that infection. In some types of fever, actually antibiotics are not required. So we should remember that all fevers don't require antimicrobial uh, as to cure that condition. So we should be knowing about which fevers require antibiotics and which are the other causes which don't require antibiotics. Inappropriate or injudicious use can also lead to resistance of antimicrobial agents. In India, we are facing a lot of antimicrobial resistance in our ICUs and in also our routine practices. That is why awareness of proper use of antibiotics is of great importance. That is why we have selected this topic for today's CME. We are having four renowned speakers for this CME who will be guiding us for appropriate use of antimicrobial agents in routine practice, in common diseases, in pediatric as well as adult age group. Then microbiological basis of antimicrobial drugs. And in last, Dr. Rahul Pandit will be telling about antimicrobial use in our ICUs. After the end of our four lectures, we are having a panel discussion with our four guest speakers. Here, you can have your question answers. You can write them, type them in the chat box. The relevant questions we will take at the end of the session in the panel discussion. So in this way, we are going to conduct a CME about the antimicrobial uses. So without any further delay, I would like to invite our first speaker. Our first speaker is Dr. Anand Malani. He will be talking on an overview of antimicrobials and management of common infection. So giving a brief introduction of our first guest speaker, Dr. Anand Malani. He is MD Medicine and a consulting physician in our Sangli Miraj area. Dr. Malani has done his MBBS from GNC Miraj. He has passed his MD from VM Medical College, Solapur. He is practicing in this Sangli area since last 20 years and is having special interest in critical care, infectious diseases, and rheumatology. He is also a task force member for COVID-19 infection. He is one of the founder member and director of Ushakal Abhinav Institute of Medical Sciences, which is an upcoming 350-bedded multi-super specialty hospital, Sangli. As far as I know, Dr. Malani is very dedicated and sincere towards patient care and very sincerely, hardworkingly, he is practicing in Sangli. So without any much delay, I would like to invite Dr. Malani for his talk on overview of antimicrobials and management of common infections. Over to Dr. Malani.
Good morning, everyone. Wish you all a very happy new year. Let me thank at the outset IMA Sangli for giving me this opportunity to talk on antimicrobials. So I will be dealing with an overview of antimicrobials and management of common infections. So why the CME title? Why at all? Yes, I'm sorry to say our awareness and appropriateness about antimicrobials are still very low, hence the title and the CME. This is the level of awareness about antimicrobials. MDR and XDR bugs, I mean multi-drug resistant and extremely drug resistant bugs are at our doorsteps and we are not aware. Imagine some patient with sepsis who is not going to respond to any antimicrobials. It's a catastrophe. And the appropriateness, it's also very low. Why to use meropenem when where levofloxacin will just be adequate and fine? So we have to give a thought about appropriateness and become highly aware of antimicrobial use. So what are antimicrobials? It's a very simple term. Anti is against, microbials means microorganisms. Anything which acts against microorganisms is an antimicrobial. So antimicrobial is not equivalent to antibiotic. Antimicrobials constitute of antibacterials, which we commonly call as antibiotics, then antifungals, antivirals, antiparasite agents, and anti-TB agents. So this is a very huge, massive topic. I will limit my talk to antibiotics or antibacterials. These are the common abbreviations used during the antimicrobial talk. This will be repeated again and again. Let us see a few of them. Few important. AMR is antimicrobial resistance. PK is pharmacokinetics. PD is pharmacodynamics. AUC is area under the curve. MIC is minimal inhibitory concentration. There are few other terms I will deal afterwards. So what is the present Indian scenario about antibiotic usage? You can see from the slide, India has used a total of 7976 million doses in year 2020. Excuse me. The use was just 5411 million doses in year 2010. So there is a 47% increase in antibiotic usage in 1 decade. What about resistance? Almost 70 to 80% of isolates are resistant for higher antibiotics like meropenem. And what is the US scenario? The antibiotic use is coming down. It is down by 20% in last 10 years. Even the resistance levels are very, very low as compared to Indian scenario. So why this discrepancy? Here are the facts about antibiotic misuse in India, which is causing the huge discrepancy. So antibiotics in India, they are most misused and overused pharmaceuticals. Many times they are underdosed, sometimes overdosed. Many times they are used for a short duration, sometimes for over duration. Many times a wrong choice, very, very important. Many times they are not at all indicated. Microbiology is either underused or not used at all. Antibiotics are available over the counter. You can get even meropenem over the counter. If you go and ask in any pharmaceutical shop, give me 1 gram of meropenem injection, they will hand it over to you. Extensive guidelines are available, Indian guidelines are available, but nobody bothers to use them. So misuse or overuse is the main driver of antibiotic or antimicrobial resistance. And the most concerning fact is dry antibiotic pipeline. Very few antibiotics have come in last few years and very few are in the pipeline. So we should be really scared. There are some false beliefs about antimicrobial usage. Higher the fever, higher should be antibiotic. Longer the better. Broad spectrum antibiotics are always safe for your patients. It's a wrong concept. Double or triple cover is always better. It applies sometimes in intensive care but not in routine care. This is a wrong concept. And treat each and every infection, treatment of colonizers and contaminants is essential. It's again a wrong concept. Let us see some examples of misuse or wrong use. Dengue fever, a very common scenario. Most of the patients are on IV ceftriaxone. Actually, they need none. COVID, very, very bad scenario we saw last year at many of the COVID hospitals or COVID centers. Many patients were on IV meropenem 1 gram 12 hourly or 8 hourly for very indication. They need none. They are needed only when there is secondary infection. URTI, augmentin 625 BID for 3 days, it's a common prescription, which is wrong. In LRTI, use piptas only for 12 hourly dose. Routine cystoscopy or some endoscopy and 1 or 2 doses of meropenem or piptas. GI infection, we always use metronidazole or ranitazole. So these are some of the examples of misuse or wrong use. So let us discuss the principles and steps of rational antibiotic use. I have divided them into 10 principles. Let us see one by one. Principle 1, most important, you have to make a clinical diagnosis and support by investigations. By doing that, by doing a clinical diagnosis, you will have some idea about the organisms you are dealing with. Example, skin and soft tissue infection, you are aware it may be staph or strepto. Biliary or GI infection, you are aware that it may be E. coli. Dengue infection, you are aware it is a viral infection, antibiotic have no role. So please make a clinical diagnosis. Please look at it whether it is an infection mimic or real infection, and don't forget to draw appropriate cultures whenever indicated. The second principle is you have to limit empiric antibiotic therapy. You have to start empiric antibiotics only for obvious infections, like a frank UTI in a diabetic patient or a yellow-colored sputum in COPD exacerbation, which indicates infection. Of course, you have to start them immediately for serious infections like sepsis, pneumonia, neutropenic patient. Third principle is know your bugs. So you should have some idea about the commensals. You should have some idea about the pathological organisms. So again, when you diagnose clinically, you will be able to predict the organisms. You will be able to predict the possible source of infection. Then you can predict the local antibiotic resistance pattern as per your institution antibiogram. After all the first 3 steps, this is the 4th step or principle. You have to choose the appropriate antibiotic and in correct dose, route, and for correct duration. You also have to consider the tissue penetration and the site of infection. So if you are treating an abscess by just giving antibiotics, it may not help to a large extent because the antibiotic will not reach the pus inside an abscess. It needs drainage. If an antibiotic is not achieving adequate levels in CSF, then there is no point using that antibiotic for meningitis. 5th principle is modification or de-escalation. You have to modify your antibiotics after culture and sensitivity report. Please avoid double coverage. You have to de-escalate to lowest possible number and appropriate antibiotic. Very common examples in ICU. If you have started empirically colistin or polymyxin, and if the culture shows there is no carbapenem resistance, then you have to withdraw that antibiotic. Same about vancomycin. 6th principle, stop antibiotics when not necessary. Again, the same points: influenza, COVID, dengue, chikungunya, minor skin infections like boils, asymptomatic bacteria. These conditions don't need antibiotics. When you diagnose FUO as SLE or RA or some other non-infectious cause, please withhold antibiotics. The 7th principle is appropriate duration. This is very important. You should be aware what dose you are going to use an antibiotic. So these are the common conditions and common the duration to which you have to treat. Septic arthritis needs treatment for 21 days and not just 7 days. Endocarditis needs at least 28 days. Osteomyelitis need more than 45 days. Some infections need even only a single dose. So always remember, under treatment will lead to a relapse. So for appropriate conditions, you have to choose the appropriate duration, even if patient becomes asymptomatic. 8th principle is optimize PK, PD parameters. PK is pharmacokinetics, PD is pharmacodynamics. This diagram explains clearly the concept. So the vertical axis shows the drug concentration. The horizontal axis shows the timeline. So this is the point where we have given IV antibiotics. So the drug achieves highest concentration in short time. This is peak concentration. Then as time passes, the level of antibiotic in blood decreases. So some antibiotics are concentration dependent to be effective. Some are dependent on area under the curve or time above MIC. We will take example of amikacin. So amikacin, the killing by amikacin is dependent on concentration of amikacin in the blood, peak concentration. So you have to give this antibiotic as a single daily dose. You can give full dose 500 milligram, 750 or even 1000 milligrams single IV bolus, then this will be most effective. If you are giving the same dose of amikacin above 1000 milligrams in an IV infusion or drip over 24 hours, the peak will be very low, so it won't be effective. So same dose when you are giving as a bolus, it's highly effective. Same dose you are giving over a slow infusion, it is not effective. About cephalosporins, they act as per AUC or time above MIC, so you have to give them infusions. So you should be aware of the PK/PD of your antibiotic and the dose and route of administration. 9th principle is antibiotic stewardship. Stewardship is an ethic that embodies the responsible planning and management of resources. So antibiotic stewardship is defined as a set of coordinated interventions designed to measure and improve the appropriate use of antimicrobials by promoting the selection of optimal choice, dose, duration, route, and hence improving patient outcomes, reducing misuse and the development of resistance. The 10th principle is about antimicrobial policy. Each and every hospital, nursing home should have its own policy. They have to follow the policy strictly, modify as and when necessary. Even small nursing homes can have their antimicrobial policy. Now, there are a lot of antibiotics in market. So how do you classify antibiotics? Antibiotics are classified broadly according to the mechanism of action, and then class and subclass. It's a topic in itself. I will not be discussing in detail. Let us just scroll through the various types of classes and antibiotics available. Beta-lactams, this includes penicillins, cephalosporins, and carbapenems. Monobactam, like aztreonam. Penicillins include ampicillin, amoxicillin, amoxiclav, and piptads. So many of us may not be aware that these all are penicillins and all are beta-lactams. Cephalosporins, first generation, oral is cefalexin, parenteral is cefazolin. Second generation, oral is cefaclor, cefuroxime. Cefuroxime is also available parenterally. The third generation, oral is cefodoxime, and parenteral are ceftriaxone, cefotaxime, cefoperazone, ceftazidime. The orange ones are which we use very commonly. The fourth generation cephalosporins are cefepime and cefpiro. And the newer one, fifth generation, still not available with us, is ceftriaxone. Next class is glycopeptides, vancomycin and teicoplanin. Then bacitracin, fosfomycin. Aminoglycosides, amikacin is most commonly used. Natrilamycin is most commonly used in intensive care units. Tetracyclines, tetra and doxycycline. Macrolides, azithromycin, clarithromycin, erythromycin, and newer one is clarithromycin. Clindamycin. These are for ICU use, quinflocristin and dalflocristin. Chloramphenicol we don't use nowadays. Oxazolidinones, the main antibiotic in this class is linezolid and tedizolid. The first one is very commonly used. Sulfonamides and trimethoprim. Quinolones, commonest used is cipro, levo, and moxifloxacin. Rifamycins, these are, even though antitubercular, these are also used as antibiotics, especially rifampicin and rifaximin. Miscellaneous nitrofurantoins and metronidazole and so on. Polymyxin and daptomycin, these are used only in ICUs. So this was about the common available antibiotics, and let us discuss a few important antibiotics. So I will be discussing commonly used antibiotics, their main uses, adverse effects, and the mistakes which we usually do. First and foremost, I will discuss azithromycin. The use has decreased nowadays. Why it has decreased? It has decreased just because of availability of newer molecules. So this is a wrong precedent. When a newer antibiotic is available, we try to underuse the previous ones. So this should not be the case. The antibiotic use and misuse should be directed. Antibiotic use should be directed as per the culture protocols and the local sensitivity pattern, and not as per the availability of newer antibiotics. So common indications for azithromycin will be acute pharyngitis, tonsillitis, sinusitis, skin infections, atypical pneumonias, and then infective exacerbations of COPD. The dosing which has to be used is 500 milligrams on day 1, then you can use it 250 milligrams twice a day for at least next 4 days. You have to avoid it if LFT is severely deranged. What are the serious side effects? It can cause acute liver injury, it can cause cholestatic hepatitis, it can aggravate myasthenia gravis, so better to avoid in a myasthenic patient. QTC prolongation can be an issue with azithromycin, especially when you are combining with other drugs which also prolong QTC interval, or you are combining with other antibiotics which prolong QTC interval. You have to be very careful. Common mistake is it is underused, but it remains still a very good drug when used appropriately. Second most commonly used drug is amoxiclav. Everyone uses amoxiclav, right from family physicians to super consultants. The common indications for amoxiclav will be upper and lower respiratory tract infection, skin infection, dental infection. The dose should be 625 milligrams thrice a day, or 1000 milligrams of extended release tablet for 5 to 7 days. It needs renal adjustment. It is deemed as a very safe drug. Here I recall a life-threatening experience with augmentin or amoxiclav use. I had one patient, elderly female, rheumatic valvular heart disease, diabetic, creat was 1.4. She was on diuretics, Amifru, which contains a potassium sparing diuretic. She had some URT and she was prescribed augmentin or amoxiclav in the routine dose. Next day, she landed up with severe bradycardia and restlessness. On evaluation, she was found to have a pulse of 40 and hyperacute T waves on ECG, indicating severe hyperkalemia, life-threatening hyperkalemia. The hyperkalemia was managed appropriately and the patient survived. But such a humble-looking drug, amoxiclav, sometimes can push patient to the brink of death if not used appropriately. So this was the creat was just 1.4. The electrolytes at the baseline were not known. Without knowing electrolytes, this was used and it caused the problem. So amoxiclav contains a significant amount of potassium. You have to be very much careful when using in patients of CKD or who are on potassium sparing diuretics. Again, it can cause allergic reactions, angioedema. Antibiotic induced diarrhea is again very common with amoxicillin. The commonest mistake, it is always used by many in BAD dosing. It has to be thrice a day. If you want to give it twice a day, please use 1000 milligram ER tablet, then you can give it twice a day. Third most antibiotic commonly used on OPD basis by everyone is levofloxacin or ofloxacin. So commonly indicated for lower UTI, the prostatitis, GI infections, intra-abdominal infections, even in pneumonias. So what is the appropriate dose of levofloxacin? So you have to use it 500 milligram to 750 milligram once a day for 5 to 15 days. Why once a day? Because again, the action is concentration dependent. So if you use in a single full dose, it will act more appropriately, more effectively. Again, in case of CKD, you have to adjust the dose. You cannot use in pregnancy or lactation. Now, the adverse effects with levoflox are very common and unthought of. Commonest is neurological side effects, insomnia, irritability, restlessness. So this is very common. Even though they look benign, they indicate predisposition to seizures. Such patients can throw seizures. Arthralgias and tendon ruptures are known with prolonged use. especially when used in tuberculosis. They can cause anaphylaxis, levofloxacin, moxiflox. Even in oral form, they can cause anaphylaxis. So whenever you are starting these antibiotics, especially on IPD basis, don't start on the day of discharge, start one day before. Again, Steven Johnson's is seen with this class of drugs. Glucose dysregulation is very, very common. This class of drugs can cause severe hypoglycemia. Many patients will need admission for the hypoglycemia. Many times it can impair glucose or increase glucose. Seizures are very, very common with this class of agents, so to be very, very careful. Especially if patient is having old stroke and scar, if patient is known epileptic, please avoid quinolones in this type of patients. QTC issue is there with moxifloxacin. What is the common mistake? It is used in a higher dose of 500 milligrams BID. It is a very high dose, should not be used in that dose. Fourth antibiotic we commonly use is metronidazole. The common indications are anaerobic infection, amoebic dysentery, giardiasis, pelvic inflammatory disease, and GI surgeries. The dose will be 400 milligrams thrice a day orally. It is absorbed almost 100% when given orally. If you need to give intravenously, the dose is 500 milligrams thrice a day. You have to adjust if there is severe renal impairment. You can use it in pregnancy only if the use outweigh the risks. Avoid in lactation. Commonest interaction is with alcohol. It can cause a severe disulfiram-like reaction when alcohol is consumed along with metronidazole. Sometimes it necessitates admission in ICU. Commonest mistake, it is used for every GI infection. We have got all sorts of combination available, all antibiotics available in combination with metronidazole and orindazole. So there's no need to use in each and every GI infection. Doxycycline, it's a broad spectrum antibiotic, covers many gram positive and gram negative rickettsia, chlamydia, brucella, spirochetes. The common indication should be rickettsial infection, leptospirosis, brucellosis, atypical pneumonias, and epididymoorchitis. The duration and dose is 1 capsule twice a day for 7 to 10 days. In some mild infections, you can use it once a day. Be careful in severe hepatic dysfunction. The commonest mistake is we are using it very commonly. We are using it for URTI. We are using it for simple GI infections. It's a broad spectrum antibiotic. You have to keep this reserved for certain and specific indications. Cephalosporins, again, common class of antibiotics available. So oral cephalosporins are available in generation 1, 2, and 3. The common indications for generation 1 and 2 are respiratory tract infection and skin infection. The dose varies as per the molecule. These are very safe drugs and can be used without worrying for the kidney or liver function. Common mistakes, again, cephalexin, a generation 1 cephalosporin, is such a wonderful drug. It is underused. It is very good for upper respiratory infection and skin infection. And cefpodoxim and cefixime, these are used for URTI. So these are third generation cephalosporins. And the coverage of these molecules for gram negative is more than gram positive. So they should be used more for GI infections and UTIs and not for URTIs. These are not hard and fast rules, but these are general dictums. About cephalosporins parenteral, again generation 3, 4, and 5. So the common indications for generation 3 will be serious biliary infections, GI infections, urinary infections, abdominal surgeries. Generation 4 are used for pneumonias and febrile neutropenias. The doses of cephalosporins are usually very high. You have to use in 1 to 2 gram for every dose, which is at least 12 hourly and many times 8 hourly. This is again common mistake we are using in very low doses, usually 1 gram 12 hourly. That is not enough for many infections. You have to administer these agents via IV infusion. Each infusion or each dose should last for 1 to 2 hours. So with this infusion, the time above MIC achieved is significantly high. That's why the drug will be more effective. If you give in bolus, the drug will be less effective. So always use these drugs in IV infusions over few hours. Common side effects, again diarrhea, LFT may get deranged to some extent. And about serious side effects, anaphylaxis, again very common. Whenever you are using cephalosporins for the first dose or first time, be prepared for anaphylaxis. This can happen even if it has been used in the patient previously or in past. So always you have to administer a test dose, either a skin test or very small volume 0.1 ml you can administer intravenously and then observe for signs of allergy or anaphylaxis. Leukopenia and thrombocytopenia are also known with these drugs. These drugs can also cause fever. So if you are not getting an explanation for leuko or thrombocytopenia in your patient, please think of cephalosporins as the culprit. Again, as I discussed, common mistake is these are given as bolus or fast infusion, and sometimes wrong choice. So in the present Indian scenario, ceftriaxone will not be a very great choice for LRTA, while cefepime is a very good choice. This humble ceftriaxone is a very higher antibiotic in the Western countries. They use it for meningitis and serious infections. In India, they are used left, right, up and down by anyone and anywhere. So making it prone to multiple drug making it prone to resistant by multiple organisms. Commonly used antibiotic, piperacillin tazobactam. It is an extended spectrum penicillin with beta-lactamase inhibitor. This is a very broad spectrum antibiotic and includes and covers Pseudomonas. Common indications, again, community plus hospital-acquired pneumonia, sepsis, and serious GI infections, UTIs, febrile neutropenias. The dose should be at least 3.75 to 4.5 grams 6 hourly, at least for 7 to 14 days. It needs adjustment if RFT is deranged. Again, the same serious adverse effects like anaphylaxis and leukothrombocytopenia. It interacts with warfarin and enoxaparin. The anticoagulant effects of warfarin and enoxaparin will be aggravated. So you might have to adjust the doses accordingly. And a very common mistake seen everywhere that this antibiotic is used in twice a day dosing, which is not at all adequate. And sometimes if the creatinine is deranged, the dose is not reduced. This is the second common mistake. Ninth antibiotic, which has become very common now. It should not be a common antibiotic. It should be a reserved drug. But the case is, it is being used rampantly everywhere, anywhere. So this is a very broad spectrum antibiotic, will covering gram positive, gram negative, and anaerobes. Please use only for intensive care purpose and as per culture and sensitivity use. Sometimes it is have to be used empirically in sepsis and other settings. The dose has to be 1 gram 8 hourly, and it needs adjustment as per creatinine clearance. Again, it can cause anaphylaxis and seizures. Very common mistake, it's used BID. It is used as a routine antibiotic. It is the most misused antibiotic. And many times the dose is not adjusted as per creatinine clearance level. This is the common mistake. Another drug I'll be discussing is linezolid. It's favorite drug with many surgeons and orthopedic surgeons. The common indications will be skin and soft tissue infections, bone and joint infections. But this has to be again a reserved drug used for culture positive staphylococcal infections which are sensitive to this drug. The dose has to be 600 milligrams orally or IV twice a day. These are again used for prolonged durations, and many are not aware of the adverse effects. It can cause serious myelosuppression within onset of which is within 2 weeks. You have to be aware of that. If you are using this drug for a prolonged period, you have to monitor CBC every weekly. It can cause irreversible neuropathy and hypertensive crisis when used with MAO inhibitors. It can induce a serotonin syndrome when used with SSRIs. These are antidepressant drugs, or tyramine-rich foods like aged cheese, processed meat, fermented food, soya beans, or bananas. So these are very serious adverse effects. You have to warn your patients to avoid these drugs and food products when you are using this antibiotic. Again, common mistake is it is again used as a routine antibiotic. It should not be. The dose used is once a day, which is a wrong dose. It has to be used at least twice a day. So after discussing antibiotics and common antibiotics as effects, let us see some clues which will point to a bacterial infection. So it will be easy for you to choose antibiotic and whether to use an antibiotic or not to use an antibiotic. So these are common 10 clues for bacterial infection. Fever with bacterial infection is usually moderate to high grade. It may or may not be with chills and ripers. There are localizing signs usually with bacterial infection. Patient will complain of throat pain in case of tonsillitis, loin pain in case of pyelonephritis, abscess, he'll have localized pain. Hypotension usually indicates sepsis, but it is early in the course for bacterial infections than viral infections. Most important, commonly we do CBC for all fever patients. So leukocytosis with absolute neutrophilia will favor a bacterial infection. Leukocytosis with shift to left band forms will again very strongly favor a bacterial infection. And normal leukocyte count but with shift to left or with toxic granules again favors a bacterial infection. Coming to lab investigations, very high CRP, usually more than 50, will favor a bacterial infection. CRP indicates inflammation. It is also seen in viral infections and COVID, but the rise is very early in bacterial infections. High procalcitonin is around one important marker for bacterial infection or bacterial sepsis. Again, elevated creatinine, the organ dysfunction sets early with bacterial sepsis than other causes of sepsis. And then when we are doing an ultrasound and X-ray and you get a localized focus of infection, it usually favors a bacterial source. So let us see 10 common conditions, or I call it as a syndromic approach or empiric approach. So this will deal you or tell you about the initial empiric choice we have to choose as per each condition. They are not hard and fast criteria or rules. Basically, your antibiotic policy and patient's culture report should guide the therapy further. Common cold, rhinitis, coryza, and COVID. Please don't start any antibiotic initially. If there is secondary infection, you can always add on. Tonsillitis and pharyngitis, you can start with azithromycin or amoxicillin or cephalexin. I will recommend to avoid cefixime and cefodoxime, quinolones and doxycycline. Viral fever, myalgia, very common these days. Dengue, chikungunya, Zika infection is also now present in India. These needs no antibiotics unless specifically indicated for some other purpose. LRTA or community acquired pneumonia, outpatient basis, previously healthy, no comorbidities, no recent antibiotic use in past 3 months, you can get away with amoxicillin or cefuroxime or clarithromycin. So again, on outpatient basis, if there is antibiotic use within last 3 months or there are comorbidities, then you can choose a respiratory quinolone like levofloxacin or moxifloxacin or amoxicillin or cefuroxime. Plus, you have to you can add one macrolide antibiotic to cover atypical organisms. If patient is admitted, non-ICU admission, You can use IV levoflox or moxifloxacin or a third generation cephalosporin and add a macrolide. For hospital-acquired pneumonia, it's a huge topic in itself. The antibiotic of choice for patients without risk factors for MDR pathogens like Pseudomonas and Staphylococcus should be IV third or fourth generation cephalosporin plus respiratory quinolone. If patient is having multiple risk factors for MDR pathogens, like he was admitted previously on many occasions, he had received many antibiotics, had a hospital stay, is diabetes, having CKD, and so on, the drug of choice of empiric initial antibiotics should contain piptaz plus levofloxacin plus linezolid so as to cover Pseudomonas and MRSA. Biliary infection, if it is mild biliary infection, no sepsis, stable patient, you can use ceftriaxone. If it is moderate to severe biliary infection or sepsis, you have to go for piptaz or cefepime plus metronidazole or straightway with meropenem. GI infection, very, very common cause for OPD visits. So we can subdivide this infection into various categories. Traveler's diarrhea, patient has had travel over last few days, had water and food at multiple locations. You can just begin with proper hydration and rifaximin pre-probiotics. No need to give higher antibiotics for traveler's diarrhea. There is mild diarrhea, no fever, no toxemia. You can use the same therapy. There is diarrhea with cramping, pain, and fever. These need antibiotics, levofloxacin or ofloxacin. You can add pre and probiotics. Frank dysentery, blood in stools, toxemia. You have to add here metronidazole or orinidazole. If patient is admitted with severe GI infection, you have to add ceftriaxone plus metronidazole. A very good combination. If patient is in sepsis due to GI infection, the antibiotic choice should be as per ICU protocol. If you think it is cholera, there is no point in using metronidazole or ceftriaxone. The drug of choice in cholera is tetracycline. So we have to suspect clinically, get the investigations done and treat accordingly. If patient is having chronic diarrhea, you have to evaluate first, find out the cause and treat. Sometimes the chronic diarrhea may be an antibiotic associated diarrhea because of Clostridium difficile. If you treat them with antibiotics again, it's going to get aggravated. So you have to prove it is antibiotic associated diarrhea and it has to be treated with vancomycin or metronidazole. UTI, again a very common scenario. Let us move through it quickly. So lower UTI or cystitis, in uncomplicated non-pregnant females, you can use a single dose of fosfomycin or short course of quinolones. In complicated means patient is diabetic or having catheter or recurrent infection. Again, in non-pregnant females, you can go for a levofloxacin full dose or fosfomycin for 2 doses. During pregnancy, you can use cefalexin or cefodoxime. You can safely use nitrofurantoin and fosfomycin. Cystitis in males, it needs a more prolonged course, levofloxacin full dose for 7 days, or you can go with full doses and full duration of nitrofurantoin, cefalexin, cefodoxime, or fosfomycin. Upper UTI means pyelonephritis. You have to start at least with ceftriaxone or cefotaxime. You can also use other third generation cephalosporins or piptaz. If it is sepsis, again risk for MDR pathogens is very high, then you have to choose more higher antibiotics. In case of prostatitis, initial 7 days you can use ceftriaxone or levofloxacin plus gentamicin or amikacin. In case of the treatment should last for at least 4 weeks. So next 21 days you can shift patient to oral levofloxacin. Skin and soft tissue infection, again a very common cause of OPD visit. If there is a single boil, it's not necessary to give any antibiotic. If there are multiple boils or patient is toxic, having fever, you can use cefalexin, cefuroxime, amoxiclav. Carbuncle may need more higher antibiotics, sometimes admission and IV antibiotics. Cellulitis, you can begin with cefalexin, amoxiclav, clindamycin. In case of necrotic fasciitis, which needs emergency surgery, you have to start a patient with meropenem or piptas plus Clinda plus levofloxacin. Otherwise, this will end up in septic shock very fast. So, drugs in pregnancy. So, we categorize these drugs into category A, B, C, D, and X. So, what is category A? Category A means the drug is generally very much acceptable, no evidence of any fatal risk in medical trials. Category B may be acceptable. Animal studies indicate low risk, and human studies either not available or indicate no risk. Category C is used with extreme caution, only if benefits outweigh the risks. Category D means there is positive evidence of fetal risk. You should avoid these drugs as far as possible. You can use them in extremely serious conditions. And category X means the risks are more than benefits. Do not use the safer alternatives are available for these drugs. So even though considered safe, some drugs can again, even some category A drugs can cause some other problems. So please keep these things in mind. So not all drugs are safe in pregnancy. As far as possible, avoid in first trimester. Just we'll go through the list of drugs which are safer in pregnancy: ampicillin, amoxicillin, amoxiclav, azithromycin, cefalexin, cefuroxime, ceftriaxone, cefoperazone, piperacillin tazobactam, clindamycin, aztreonam, fosfomycin, and nitrofurantoin. So these are safe drugs in pregnancy. You can use them whenever indicated. Very big issue is about dose adjustment. People think it's a very complex and complicated issue. It's a very, very simple thing to calculate dose as per RFT. You have to calculate the creatinine clearance of the patient. There's a formula called as Cockcroft-Gault method. It needs only patient's gender, age, weight, and creatinine levels. So there are many apps available which will calculate creatinine clearance for the patient. And the drug inserts and apps will also mention the appropriate dose reduction for the antibiotic as per creatinine clearance. One common, very easy to use application is Medscape. Medscape and UpToDate, and all this will have the calculation for RFT adjustment of antibiotics. One more common scenario: how to check drug interactions. There are many interactions. Each drug interacts with so many other drugs. It is impossible to remember them. Now, with the advanced technology, these interaction checkers are available on your mobile. Very easy. You have to install the Medscape application or Lexicom application on your mobile. Some are free apps, some are paid apps, and this is the result you get when you use this. And this is I want to use pantoprazole, linezolid, and sertraline in the same patient. I feed the application with all these molecules and check for interaction. So the app will give me a warning or indication. So it says you cannot use this combination. There is a serious interaction between linezolid and sertraline. You have to avoid this. So it is very simple. You can take a screenshot of this and you can save them as medical records when you are using multiple antibiotics or interacting antibiotics. This was about antibiotic interactions. So coming to the last slide. So this is the 10-clause antibiotic pledge. I will use only when needed. I will choose wisely and as per suspected pathogens. I will use microbiologic methods. I will use them in appropriate dose and for appropriate duration. I will administer them appropriately as per PK/PD parameters. I will watch for reactions and interactions. I will keep some reserved. I will de-escalate as patient's condition permit. I will encourage and pursue antimicrobial stewardship, and I will follow the hospital antibiotic policy. And to be appropriate and aware, we all need to pledge. We all need to display this in our hospitals, the 10-clause pledge. So thank you very much. This was all about antibiotics. Over to MOC. Thank you.
Thank you, Dr. Malani, for nice and elaborative talk on antimicrobial uses in adult practices. It was very nice listening to you. I think the concepts of everyone has cleared whether to use antibiotics, when to use antibiotics, and when not to use antibiotics. So question answer session we will be taking later. Now I would like to invite our next speaker, Dr. Jyoti Chidgupkar, Madam. Coming to the brief introduction of Dr. Jyoti Chidgupkar, Madam, she is a microbiologist and she is HOD and consultant microbiologist at the Department of Microbiology and Molecular Laboratory, Ashwini Hospital, Solapur. She is consultant for hospital-acquired infection control. She is a vice president of IMAMS, Maharashtra State Indian Medical Association. She has got a Women Empowerment Award in National IMA, which was held in 2019 at Goa. She also received Doctor's Day Award from IMA in 2020. She is recipient of many appreciation awards from IMA Rotary. She is member of different committees of government and other organizations. Her talk today is regarding microbiology as a basis for antimicrobial usages. So I invite Dr. Chidgupkar, Madam, for his next talk. Welcome, Madam.
Good morning, everyone. After listening very nice lecture on antimicrobials, now we'll go to basic of microbiological basics of antibiotic use. The majority of the infections are bacterial in origin. With the discovery of laboratory methods to grow these microbes using appropriate growth medium known as culture, determining the sensitivity and resistance of the specific pathogens to the wide range of antimicrobial agents becomes necessary so that healthcare providers can immediately institute proper treatment regimens to their patients. AST, commonly called for antimicrobial sensitivity testing. What are the uses? It guides the physician in choosing correct antibiotics for empirical treatment. It reveals changing strain in local isolates. It shows local pattern of antibiotic prescription and a large scale. It aids in evaluation of treatment services provided by hospitals, clinics, and national programs for control and prevention of infectious diseases. So antimicrobial susceptibility testing or AST is a widely used method of evaluating antibiotic resistance and determining patient treatment plans in clinical settings. Clinical laboratories currently employ several methods depending on the laboratory test menu that they provide. These approaches, they are mainly on distribution method or MIC method. Commercial systems, which are nowadays available, they may use phenotypic as well as genotypic characterization of bacterial resistance. Despite the differences in the techniques for susceptibility test, all laboratories must be critical on each step of sampling and testing process so that the results are obtainable with consistently high levels of accuracy and reliability. And that's why we must know how the sampling for microbiological testing, for cultures, for sensitivity testing is very important and it plays key role in getting the results. So this is a diagnostic cycle where physician examines the patient, prescribes the test, collects proper sample, transports in proper container for proper conditions to laboratory. In laboratory, Analysis starts after registration by microscopic methods where a presumptive diagnosis is possible. This is a pre-analytical stage. Then in analytical stage, the specimens are subjected to different tests. They are cultured, they are identified. The organisms grown, they are even subjected to antibiotic sensitivity testing. And then in post-analytical phase, the reports are prepared and they are communicated to patients as well as physicians for further management. So what is the general consideration in microbiology laboratory is never ever possible, whenever possible, specimens should be obtained before antibiotics and other antimicrobial agents have been administered. It's very important to remember that they should be transported in proper conditions and in leak-proof containers, and they should be collected from from a area or from the location where the most likely organisms are expected, and there should be no contamination. The stage of disease may affect the success of the results. Then quantity should be sufficient and prompt delivery is as far as possible. The specimen should be transported as early as possible, but within an hour is possible. But if not possible, it should be the specimen should be refrigerated, except the samples like CSF and blood, they are not refrigerated. This is a chart which shows the different samples, the method of collection, and likely organisms isolated. Blood, generally 3 samples with the interval of 1 hour, depending prior to antibiotics, of course, depending upon the indication. Then for urinary tract infections, clean cash midstream urine. For CNS infection, CSF and blood. For wound aspirates, deep wound swabs, drainage tissue. For bone aspirates and bone marrow pieces or synovial biopsy. For upper respiratory tract, nasopharyngeal swabs and tonsillar swabs are advised. For lower respiratory tract, sputum, bronchoscopy secretions, tracheal aspirates, lung aspirates, biopsy and blood. And for GIT, gastric duodenal or duodenal biopsy, and for lower GIT, that is stool and rectal swab along with blood are recommended. This is blood culture. This is how the blood culture is collected. And the critical part is sterilization of area for blood culture. So many things they are required while collecting the blood, and proper pressure bandage is important. So to collect the blood, how much sample we should collect for adult or adolescents? Generally 20 ml in 2 bottles, that is paired sample. For one is anaerobic and for one is aerobic is recommended from peripheral or central, as far as possible from peripheral vessels. Then for older children, 5 ml is sufficient. For infants or neonates, 1 to 3 ml is sufficient. So in general, in clinical microbiology, conventional methods like microscopy, differential and special stains, cultures and serological methods are used. And in advanced rapid or molecular methods such as identification sensitivity systems, then PCR systems and automatic incubators are used. Then we now, after knowing how to grow how to collect the samples, how to grow the samples in laboratory, the most important part in antimicrobial use is in vitro antimicrobial susceptibility testing. And the goal of testing is to assess the activity of an antimicrobial agent on bacterial or fungal strain in order to predict the likelihood of in vivo efficacy of antimicrobial therapy when the antimicrobial is administered to the patients. To monitor the evolution, of bacterial and fungal resistance may be therapeutic or epidemiological. So, the data from routine antimicrobial susceptibility testing performed in laboratory influences the therapeutic decision for current and future patients. Now, important part in sensitivity testing is MIC. We have already heard about MIC. It is a lowest drug concentration that inhibits the visible growth of microbes after certain incubation. So, lower the MIC, higher the susceptibility, or higher the MIC, lower the susceptibility or maybe resistance. So the specific MIC, that is also called as breakpoints, it distinguishes susceptible and treatable from resistant and untreatable microorganisms. However, breakpoints can vary according to examined specimens and the examined species or examined antibiotics. So antimicrobials with low MICs compared to susceptibility breakpoints should be preferred, or in other words, the MIC, the antimicrobials which show the MICs nearer to the breakpoint should be selected. That's why knowing the susceptibility is important, and depending upon the methods we employ, the susceptibility is categorized as susceptible, intermediate susceptible, or resistant. These are the different methods like phenotypic methods and genotypic methods, amongst which manual methods like this diffusion method, very popular agar-dish diffusion method. Then dilution methods is agar and broad dilution and microbrad dilution methods. Then semi-automated or automated techniques like Vitek 2, Phoenix and Microscan, they are available in market. Novel techniques like biosensor based on either chip colorimetry, electrical conductivity, microfluidic droplet analysis, and surface plasmon resonance. Genotypic measures nowadays becoming popular by using the technology of PCR or microarrays. Then mass spectrometry, flow cytometry, and real-time optical AST methods are also being evolved. This is just to revise phenotypic methods by classical methods such as chromogenic media, agar broth or dilution, this diffusion and gradient test, and genetic methods by using nucleic acid amplification testing, and genomic by next generation sequencing. This is just highlights of susceptibility testing. The very commonly used disk diffusion test, where the discs are impregnated with the antibiotics and they are placed on the agar top, inoculated with the suspension of microorganism, and after incubation we see for the growth inhibitory zones, clear zones, that is zone of inhibitions, to determine whether the microbe is sensitive to that particular antibiotic. Then in this diffusion, second method is Stokes method, where the control organism is used to compare the sensitivity of test organism. Then methods which measure MICs, these are broad dilution methods, macrobroth, which are where test tubes are used, and microbroth, where micro titer plates are used, which are miniaturized, and the clearing or their complete inhibition of the growth is seen by turbidity, and the MIC is calculated. Same way, agar dilution, the serial dilutions or twofold dilutions are used in agar. The antibiotic is incorporated in that agar and studied for the growth of the microbes after inoculation. Third method is antimicrobial gradient diffusion. In this form, the concentration gradient is established in an agar medium onto which a standardized suspension of microorganism is inoculated. The microbial gradient strip method combines the principle of dilution as well as diffusion method. Example is E-test. And all these interpret the results by using UCAST or CLSI guidelines. So you can see this is a gradient method, sorry. This is gradient method where these strips are incorporated with the antibiotics and the MIC with graded antibiotics, and so we can see the zone of inhibition, and where there is a cutoff, that is the MIC. This is broad dilution, macro broad, this is micro broad dilution, this is agar dilution method, again this is broad dilution and micro broad dilution, and you can see here we can also get the MICs of fungi like Aspergillus by growing them on plates incorporated with antifungals. These are the some of the automated method like Vitex and Vitec 2C. This instrument reads the kinetics of the growth, where every 15 minutes this reads the optical using an optical system which combines with the photometer and a multi-channel fluorometric readings to assess fluorescence, turbidity or colorimetric signals. Then microscan method. This is microscan walkway system. It is an automated commercially available instrument which can process 96 panels at a time, and this system detects bacterial enzymatic activity, and the system uses fluorogenic substrate and pH indicator. Then third, very popular again, is BD-Phoenix system. Here the panel is monitored every 20 minutes by colorimetric and fluorescence reading for an identification and sensitivity testing, which is based on redox or turbidimetric detection of the growth. So Vitec Phonic detects growing bacteria on basis of turbidity, whereas comparable automated systems like Macroscan or Aris2X, they use fluorescence emission of the growing bacteria. New methods like isothermal microcolorimetry, where heat generation is studied, and nowadays one more method, polymerase chain reaction based methods, they are very popular, becoming very popular for detection of resistant genes, which are based on genotypic techniques, and both conventional as well as real-time testing is utilized in this, and this relies on the amplification of DNA sequences that are specific for a particular pathogen and its drug susceptibility or resistance. Then LAMP again is a PCR method where instead of Taq polymerase, BST DNA polymerase is used. In general, PCR based methods are efficient, reliable, and fast screening tools with high specificity, sensitivity, and with the test results available within 2 hours. So this is PCR, different PCR methods, and this is PCR machine, which this NAT method, that is nucleic acid amplification testing, is a powerful tool for this antibiotic sensitivity as well as identification when combined with the syndromic approach. And the innovations in electronics, biosensor techniques, optics, microfluidics, hybridization technologies, and DNA amplification technologies have yielded new approaches in AST. This is again one more new approach, which is MARDI-TOF MS, short form of matrix assisted laser desorption ionization time of flight mass spectrometry, and this is discovered very recently in 1980s, and the device analyzed relatively large biomolecules, and this method is based on determination of mass to charge ratio and strain differentiation using their ribosomal proteins. It does not depend upon metabolic activity. It directly identifies the colonies of gram-negative and gram-positive bacteria and yeast within minutes. You can see the bacterial cultures are subjected are placed in MARDIT of MS, and we will get the results very short, within very short time. Again, one more recent technology which is based on advanced nanotechnology and bioengineering methods, that is microfluidic devices and micro droplet method. Again, this will help in getting very fast results. So many methods, newer methods, they are in pipeline. So these are the new near future alternative and long-term alternative methodologies where we nowadays can expect in our future that the results of antibiotic antimicrobial testing for different microbes we will get within very short time, instead of 72 hours, 48 to 72 hours in old days, using so many technologies which are depending on fluorescence, magnetic technology, nanotechnology, gene sequencing, bacteriophage amplification, mass spectrometry, and so on and so forth. You can just see that how fast we are able to get the results with routine conventional methods. It was 72 hours. Then with rapid semi-automated methods or automated methods, it is for 40 hours. And now using polymicrobial or microarray methods, it is giving results within 2 to 3 hours also. So you can see this is a picture to know how the melt curves are formed in PCR by PCR technology, and we can get identification as well as sensitivity results within hours. Just to show the time frame, it is 48 hours. Up to 48 hours by conventional methods. By phenotypic methods, automated may require 7 to 8 hours, and by using nucleic acid technologies or mass spectrometry, absolutely within 2 to 4 hours we are getting the so why all these technologies are required? It's just because of antibiotic resistance, which is evolving nowadays and which is very much responsible for the lot of deaths, that is morbidity and mortality due to just because of failure of the drug. So, or failure of the antimicrobials. Alexander Fleming, by accepting the Nobel Prize, he said that then there is the danger that the ignorant man may easily dose himself, and by exposing his microbes to non-lethal quantities of drug and make them resistant. And it has come true by using, by misuse, not using, by misuse or overusing the antimicrobials. Just before going to mechanism of antimicrobial resistance, these are the target molecules where by antibiotics it's themselves they act. These are the cell wall, then folic acid synthesis, DNA, protein synthesis, cell membrane, again the same thing, cell wall synthesis affected by vancomycin or chloramphenicol, cell wall integrity by beta-lactams, DNA synthesis by metronidazole and DNA gyrase by quinolones. Then cytoplasmic membrane by polymyxins, and protein synthesis is affected by say chloramphenicol also, and by tetracyclines. So after lot of misuse, abuse and overuse of antimicrobials, multi-drug resistant bacteria have evolved, and they have been called as superbugs. Not only resistant but multi-drug resistant, superbugs have evolved, and the use of these antimicrobials in even animal husbandries and agricultural areas also has affected the sensitivity of the antibiotics. So you can see this example, the doctor in this cartoon is saying that there is so much of the penicillin in this milk that if we bottle it, we could use it for to treat the fever. So this antibiotic resistance, it is the ability to resist the effect of antibiotics, and it causes the infection, and it results into the severe infections. Again, one more cartoon to show that antibiotic abuse, it produces the resistant mutants, and the cartoons is saying that hey kid, stick this in your genome and antibiotics can't even touch you, is saying to the bug. This is the development of antibiotic resistance since 1940. From penicillin, it has started. Until today, the antibiotic resistance is evolving. Gradually, this resistance developed to tetracyclines, methicillins, gentamicin, to vancomycin, quinolones, cephalosporins, and nowadays even to carbapenems. The factors contributing to the antibiotic resistance, they are environmental, drug-related, patient-related, as well as physician-related too. I'm very sorry to say it. How the bacteria acquires resistance? This is natural resistance as well as acquired resistance. Natural resistance is a permanent character. For example, gram-negative bacteria, they are resistant always to glycopeptides. And acquired resistance, this is not a permanent, it is unpredictable evolutionary resistance, and it justifies the need of susceptibility testing for the bacteria. Now, what are the mechanisms? There are either genetic mechanism and biochemical mechanism. Genetic mechanism, they are mutation of the gene. This results in reduced antimicrobial binding. Example is the quinolone resistance due to modification of DNA gyrase in Enterobacteriaceae. Second is acquisition of resistance gene transferred from strain belonging to an identical or different species. This here plasmid plays important role, and with this mechanism happens in the example is resistance to ampicillin in E. coli or protease. The biochemical mechanisms, there are 4 biochemical mechanisms. You can see the modification of the antimicrobial target results in reduction in the binding. This is example is PBP binding, penicillin binding proteins in Staphylococcus. Second is enzyme inactivation. The example is penicillinase, which is inactivated by Staphylococci, or beta-lactamase inactivated by Enterobacteriaceae. Third is impermeability of the bacterial outer membrane by alteration or quantitative decrease of the porins. Imipenem resistance in Pseudomonas is a popular example. Then efflux mechanism is the last, where expulsion of the molecule by active transport occurs. This tetracycline resistance in Staphylococcus. So to summarize, blocking entry, inactivating enzymes, then alteration of the target molecule, and efflux of the antibiotic are mechanisms for the antimicrobial resistance. So in community, how the resistance spreads, it can spread from animals, from agricultural overuse of the antibiotics, as well as overuse of antibiotics in patients, as well as in community. And this and the selection, because of selection pressure, the resistant mutants, they evolve and they spread throughout the community as well as in the healthcare facility. So simply using antibiotics creates a resistance, and these drugs should only be used to treat infections and nowhere else. Again, this is, you can see a lot of germs, they are there, and very few initially they are resistant. When we use antibiotics, these sensitive and bacteria, they are germs, they are killed, and only resistant remain, which multiply and they spread the resistance to other bacteria also. So antimicrobial do not cause resistance, but may allow resistant mutants to proliferate by eliminating susceptible organisms. And this is known as selection pressure. The increase in the frequency of resistant strain is often linked to increased use of specific antimicrobials. This is the mechanism of antibiotic action versus the mechanism of antimicrobial resistance. So by overuse of this antibiotics or antimicrobials, we should know that it is becoming a silent killer, and this overuse we must stop, which is very high in India, or we will lose all the life-saving antibiotics in near future. So acquisition of antimicrobial resistance mechanism can render previously useful antimicrobial agents useless for treating most strains of species. Therefore, susceptibility testing becomes essential for the detection of acquired resistance. This is a message from microbiology laboratory. And secondly, antibiotic susceptibility testing at the interface between the clinical diagnosis and therapeutic decision is a key element essential for guiding both microbiologically documented and empiric antibiotic therapy. Not only is the susceptibility test a result of immediate interest for the clinician to guide selection of antimicrobial therapy, but it also helps, or it also plays a role as an epidemiological surveillance tool for local bacterial and fungal resistance pattern. So just requesting everyone to use antimicrobials very rationally in your day-to-day practice. Thank you very much.
Good afternoon, everyone. I am Dr. Geetanjali Gupte, practicing as physician in Sangli. Thanks a lot, Dr. Mrs. Jyoti Chidgupkar, for a very informative lecture. We will be using this information in our day-to-day practice, and it will be very useful in treating patients and their outcome. Now I request Dr. Vinayak Patki to join us in this meeting. He is going to speak on rational use of antimicrobials in pediatric age group. Dr. Vinayak Patki is the Chief Consultant and Head of Advanced Pediatric Critical Care Center at Wandes Hospital, Mirrors. He is Editor-in-Chief of Journal of Pediatric Critical Care, is Joint Secretary IAP Intensive Care Chapter, is Executive Member of Academic Council of IAP College of Pediatric Critical Care, is National Coordinator of Essential Pediatric Intensive Care Course in India, is National Convener of IAP TIPS. He has more than 100 scientific international publications on his name, is Program Director of Pediatric Intensive Care Fellowship Program and National Faculty for Essential Basic and Advanced Pediatric Care Course. I welcome Dr. Vinayak Patki to deliver his lecture.
Good morning, everybody. First of all, I would like to thank IMA Sangli for giving us opportunity to talk on rational use of antibiotic in pediatric age group. So what is basically we should know it is what is irresponsible or irrational antibiotic use. Antibiotics are being prescribed for indication in which their use is not warranted. In between 2005 to 2009, A survey told us antibiotics sold to around 40% more. Antibiotics are treated as antipyretics, and all the febrile illnesses are referred as antibiotic deficiency states. This is because the clinician's erroneous trust in antibiotics, which is further computed by the wrong belief that they will prevent the secondary bacterial infections. So what is why rational antibiotic therapy? So what is the basic idea behind rational antibiotic therapy is principle is you can combat antimicrobial resistance, better care of patients, prevent misuse of antibiotics, and reduce the cost of the treatment. Finally, brunt of this whole system has to go to the patient. That's what we can reduce it. So unless and until we know what is the how to combat about antimicrobial resistance, we cannot go to a what is rational and how we should proceed about rational antibiotic therapy. So antibiotic resistance and global warming, there are a lot of similarity between the two facts. One is burning issue. These are both are burning issues, well tolerated. It's a very, that means there is no sense of urgency saying from any part of the world. Everybody's matter, but effects on the mankind. And but the main difference is unless the global warming, antibiotic resistance is not well recognized among the outsiders. So we have to define the antibiotic resistance. Antibiotic resistance is defined as microorganisms that are not inhibited by usual achievable systemic concentration of an antimicrobial agent with normal dosage schedule or fall in the MIC. So that means a routine dose of antibiotic is not going to affect. How the resistance develop? Usually, normally what happens when you give antibiotic, there is a death of that bacteria. But when the bacteria becomes mutant, even in spite of antibiotic application, it survives and it continues to reproduce and produce offspring that are resistant antibiotic used to treat it. This is basic about antibiotic resistance. We will not go in the details. I think microbiology, previous my lecture has been covered this basic facts about this antibiotic resistance. Just I am giving you the glimpse of antibiotic resistance. So what has happened? So if you see from 1930, the first sulfonamide has been discovered and the last antibiotic was daptomycin. So as we go on advancing in achieving the newer advances in antibiotic deployment, antibiotic resistance is also getting slowly absorbed, and now almost all the antibiotics are some or other percentage are getting resistance, and this is a worrisome fact. Then we should know what are the factors of antibiotic resistance. It is drug. There are multiple factors, drug-related factors, then environmental factors, then prescriber-related factors, patient-related factors, and all these multifactorial combination causes antibiotic resistance. So what is the paradigm? Basically, what is happening is excessive and inappropriate use of antibiotic give rise to antibiotic resistance. That's what we have learned. And what happens that failure of, so whenever we use these antibiotics in a resistant situation, that causes a failure of antibiotic therapy, which again causes excessive and inappropriate. Though this becomes a vicious cycle. This is called as, this is what we can see it as antibiotic paradigm. So just coming to what is the ICMR data, this is recent data. It is estimated that by year 2050, Asia will have 4.7 million deaths that could be directly attributed to the antibiotic resistance. So AMR is rampant in India, so 12 to almost 60% of E. coli being extended beta-lactamase producers, and up to 30% being carbapenemase producers. Klebsiella has emerged as in the last 5 years as a highly resistant pathogen, and resistance is up to 50% to the carbapenem and rapidly increasing to the polymyxin also. And in addition to that, MRSA is going up to 30% in Staph aureus isolated nationally. So these are some figures which is very worrisome for all of us. Why do the commonest situations of antimicrobial use? So what are the reasons where we come across misuse? So fever without focus, minor skin infection, non-specific upper respiratory tract infection like rhinitis, pharyngitis, then bronchitis, asthma, gastroenteritis, non-infectious fever. This just to prevent the secondary bacterial infection, to prevent bacterial infection of normal newborn. there are a lot of colonization and culture contamination. These are some situations where antimicrobials are misused. So before going to actual rational use of antibiotics, I would like to take you to some cases, because if it a case-based discussion, you can able to learn it in a better way. So this is the first case, Apurva. This is a 1 year, 6-month-old female brought with history of fever, cough, and rhinorrhea for 2 days. She has red eyes. She has diarrhea, no exanthem. Cough is there, mild cough with similar history in the families. Her throat is congested. So how will you manage? What are your thoughts? It is very easy. Before giving you thought over this case, I would like to take you to a second case. See, this is a Mehul. This is a 4.5-year male. Mehul brought with your clinic with 2 days history of high spiking fever and mild cough. From history and examination, he has red eyes with rhinorrhea, no exanthema, difficulty in swallowing, and no history of similar case in the family, and he looks sick even when he is afebrile. So these are the 2 cases. What is happening to Mehul on examination? Respiratory rate is 28, heart rate is 1110, perfusion BP is normal, tonsils are enlarged, as you can see in the picture. They are purulent, discharge is there, with inflammation is there, and bilateral tender cervical lymphadenopathy. Ear, nose normal, and a systemic examination is normal. So this is the second case. How will you manage this case? So I have discussed 2 cases with you. One is Apurva and second is Mehul. So what is the difference? Apurva came with acute onnets, red eyes, rhinorrhea, cough, no rash, pharyngeal congestion is there, but no exudates, no cervical lymphadenopathy. So all this suggests is mostly probably a viral infection. What is happening to Mehul is acute onset throat pain, but he's toxic, enlarged tonsil, purulent discharge, standard cervical lymph. He's sick looking, and age is more than 3 years. So most probably this is a bacteria. So what are the causes in major in up to 3 years of age or in pediatric age group? Etiology is viral. Most of the things is rhinovirus. This is quite common in this kind of season. Common cold 60%, then can have influenza virus, para-influenza, enterovirus, adenovirus. Sometimes you can have specific like Coxsackie, herpes, and Epstein-Barr also can give rise to. So this contributes a major cause. Bacterial causes are common, but as compared to viral cause, it is rare. Common causes group A beta hemolytic streptococci, all of us know in more than almost 30% in more than 3 years and less than 5% in 3 years. So and rarely you can have diphtheria, Haemophilus influenza, and other can be etiology. So this is again 4 months later. This Mehul comes back with fever, cough, and coryza, and see his throat. So it is this is a treating pediatrician consider him as a viral pharyngitis. So pharyngeal erythema is most of the times it is non-bacterial, and this is very important. You should, do you agree with this fact? So this is very, very important that pharyngeal erythema is not always a bacterial. This is most of the times it is viral. See, these are the more common non-bacterial pharyngeal inflammation. You can see on left side. This is this you can get in other viral infections like herpes and all this. This is a here typical aphthous ulcer is there. You can get similar picture in Kawasaki also. These are non-bacterial causes of pharyngeal inflammation. Now going to third case, this is other 15 months, otherwise healthy boy, had rhinorrhea, very high grade fever for 102 days. On day 3, he becomes fussy, woke up in the crying multiple times in the night. So what it could be the wrong, how does he evaluate this child? So during examination of his eyes, he's having erythema, fluid, impaired mobility, and acute symptoms. So this suggests that this other has acute otitis media of right ear. So how do you manage acute otitis media in under 2 years? Mainly analgesic, antibiotics. We'll see in details what are the choices, but most of the times it is amoxicillin or coamoxicillin, or in second line can be cefaclor or ceftriaxone. Decongestants have no role here. Then coming to fourth case, that is Jignesh. This is a 10-month-old Jignesh, illness for 2 days. He started with vomiting for 6 to 7 times in a day. Then he had fever. Frequency of stool around 10 to 14 days watery. He is having weaning. He's on breastfeed, but he's on weaning diet. He's looking depressed air, dry skin, sunken eyeballs. So how will you manage Jignesh here? Jignesh is come in winter season, he's an infant. So most of the time this is, you have to think about viral. Most of the diarrhea in infantile age group is a rotaviral diarrhea. And we should ask whether it is bottle feed or not, and how you are going to, what should be the protocol for management if child comes with acute diarrhea. If palar, purpura, oliguria is there, you should hospitalize. Then you have to find out whether it is with or without blood. With blood is called as dysentery, without blood is called watery diarrhea, mostly the rotavirus. Assess the dehydration, and accordingly you have to manage with oral rehydration solution plus zinc. So this is a recommended therapy, and very, very important thing, there is no role of antibiotics in this case. But if you see, whatever 3-4 cases I have discussed, most of the cases are being treated with irrationally with antibiotics where it was not needed. So what is rational antibiotic therapy, and what should be the simplified approach? So this is the next few almost 15-20 minutes I am going to discuss these things. So when antibiotic is needed, so antibiotics are needed like definitive therapy when proven pathogen with or without antibiotic susceptibility result is there. You can have empirical kind of therapy where your infection is most likely, but exact organism and sensitivity is not. And this is the more common antibiotic therapies prescribed in most day-to-day practice in both pediatric as well as in adult practice. Pre-emptive infection is probable, not proved, and prophylactic therapy, which is beyond today's scope of lecture, so we are not going to discuss here. So what is definitive antimicrobial therapy? As I already discussed, we have establishing microbial diagnosis by cultures, or different methods are there, which has been covered in previous speaker in microbiology lecture. So initiation of antibiotic therapy pending cultures and sensitivity reports, and you have to interpretation of this culture sensitivity pattern to guide the antibiotic therapy further. So this is called as a definitive antimicrobial therapy. But most of the in clinical situation, it is very difficult to start a definitive antimicrobial therapy on day one because you are not knowing the responsible organism. So what we are doing is a empirical therapy. What are the different situations where we can start empiric therapy? Clinically certain bacterial infections like community acquired pneumonia, otitis media, very rarely nowadays diphtheria, bacillary dysentery, acute lymphadenitis, cellulitis. So these are the where you this is a clinically certain bacterial infection. Then you have what is high probability of bacterial infections. While waiting, you can wait for lab results. That is suspected enteric fever, urinary tract infection without sepsis, early phase of infective endocarditis, and osteoarticular infections where there is no hurry, but you can wait for lab results. Then high probability of bacterial infections and waiting is dangerous, like septic shock, where every minute is and every hour is important in the patient management. Then febrile neutropenic patients, the patients with suspected bacterial meningitis, and sick looking neonate with, you have to start a empirical therapy. And fourth category, what we can call it as atypical course of a viral infection. That means post measles pneumonia, post H1N1, or during the management of COVID where they are becoming immunosuppressant and they are likely to get a bacterial infections. So this is a atypical course of viral. So these are the four major categories of empirical therapy. So how do you choose an empiric antibiotic therapy? Establishing a clinical diagnosis, first and foremost. These are the 5 steps. And we'll go on seeing each step in detail. So first is establishing the clinical diagnosis, viral or bacterial. Then we have to find out what are the host or organism related factors. Then which is the likely organism. So that's how first will come as organism, then will come as antibiotic. Then which antibiotic appropriate for the given situation for the given organism. And the last question we have to answer is what is the route, frequency, and duration. Let's see one by one. First question is establishing a clinical diagnosis, whether viral and bacterial. Can you differentiate between viral and bacterial infections? The answer is yes. Viral infections affects multiple mucosal system of a body. Fever is high at onset but settles down within 5 days. Child is comfortable during interfebrile period. Similar cases in the family or in the community. CBC is not contributing because polymorph nuclear predominance is in first stage, and here antibiotic has no role. How will you otherwise in bacterial side, bacterial infections are localized to one system or organ. Fever is moderate to start with and peaks by 4 to 5 days. In wherein viral it starts lower down in 5 days. Child looks sick, often toxic during interfebrile period. Draining lymph nodes are often enlarged, and where you can start narrow spectrum appropriate single antibiotic. Second question is, what are the host and organism related factors? So factors deciding what are the host related factors, clinical presentation including the site of it, whether it is upper respiratory tract, lower respiratory tract, lower urinary tract, upper urinary tract, age. Neonates are more susceptible, so their JFR is different. So you have to consider a lot of things, whether the child is malnourished or not, whether it is nutrition status is there or not, whether his immunized status is proper, whether he is immunized with routine for communicable vaccines he has been then whether he is vaccinated in properly, whether he has missed some doses or not, whether he has been received prior antibiotics. So all these factors you have to consider before choosing an antibiotic. Then other side is what is called as an agent or drug related factor. That means what is the local drug sensitivity pattern, whether the microbial drug resistance pattern is there in the community. So what is the local epidemiology? So this, and now last but not least is a pharmacokinetics and pharmacodynamics aspect of the drugs, which I am not going to cover because of my previous speakers have proven enlighten this issue. Then the next question is, what is the likely organism? So you know what is so it is important there. So if a child is coming to with tonsillopharyngitis, usually has group A beta hemolytic streptococci. Rarely, if unimmunized, you can have corynebacterium diphtheria. Acute otitis media, sinusitis, you can have streptococcal pneumonia, H influenza, or Moraxilla catarrhalis. Considering pneumonia, usually strep pneumonia, H influenza. Very rarely you can have Staphylococcus aureus and mycoplasma. Enteric fever, you know, Salmonella, typhi or paratyphi. Dysentery can be because of Shigella. Urinary tract infections are because of E. coli, Proteus or Klebsiella. And pyogenic meningitis, as age goes, pneumonia, H pneumonia, then S streptococcal pneumonia, and Neisseria pneumonia. These are so you are whenever you come across a picture of a clinical picture of whatever I have discussed, first you should try to think about what are the responsible organisms, which I have already. This is about community acquired infections. About hospital acquired infection, there will be a next lecture after me from Dr. Rahul Pandit. He is going to discuss this in a more detail. But just I will give you a glimpse of it. Vascular related bloodstream infections related to because of coagulase negative staphylococci, then enterococci, MRSA, pseudomonas, then urinary tract catheter related what we call as SCOTY. That is because of E. coli or gram negative bacilli. Ventricular associated pneumonia is because of MSSA, Haemophilus, enterococci, and overall hospital acquired infection late onset is because of Acinetobacter, MRSA, and Pseudomonas. But the next lecture will be covering, so I am not going to discuss anything about hospital acquired infections in my lecture. Next question is, what is the route frequency and duration? This is very, very important. So most of the times in seriously ill patient, we have to using intravenous route. And where you can use oral route as a switch therapy from IV or when there is non-serious infection. How we are going to decide the dose frequency is dependent on the two things. What are the whether it is a time dependent antibiotics or whether it is a concentration dependent antibiotics. So usually for becoming the long story short, beta lactamase are long time dependent antibiotics, so that needs to be given as quite frequently. As compared to aminoglycosides or fluoroquinolones, they are concentration dependent antibiotics, so needs has to be given very high dose and at a maybe single time therapy. So that's why so you should know about each and every drug, what are the pharmacokinetics of that drug. Then the duration of the therapy is also important. Usually community acquired pneumonia. So what are the short durations are there? Usually they are there for immunocompetent host or non-complicated patients. And long duration is there for usually the like example for cellulitis, pyelonephritis, either in the immunocompromised host or there is are the complications of that disease itself. So this is a common list. Usually meningitis is required for 3 weeks and osteomyelitis are usually required for 4 to 6 weeks. So this is a usual because duration of therapy has a very important in any antibacterial antimicrobial therapy is concerned. Then the last question is which antibiotic is appropriate for given situation. I think just we'll spend some time here because I'm discussing about rational therapy in pediatric practice. So tonsilopharyngitis usually above the 4 years and amoxicillin is the drug of choice. Acute otitis media again amoxicillin 40 milligram per kg for 10 days, less than 2 years otherwise for 7 days. Otoscopy is very, very important to find out the status of tympanum. Sinusitis is often underdiagnosed thing. Here again amoxicillin is given 40 milligram per kg. Pneumonia I already discussed. If it is a non-serious, it is usually amox or co-amox claim. Or in if a child is becoming sick or more severe pneumonia, you can have ceftriaxone as a drug of therapy 100 milligram per. Cellulitis, impetigo, or any skin soft tissue infections, first generation cephalosporins are more than enough to treat, like cephaloxin or cephadroxil. Lymphadenitis, check for recurrence and all that. Again, so if you see, we are using amoxicillin and first generation antibiotics for majority of the treatment in if it is a bacterial origin of pediatric infections. Then coming to bacillus dysentery, cefixime is the remains drug of choice. UTI again amoxiclav or cefixime. Enteric for we know cefixime or ceftriaxone. And pyogenetic meningitis ceftriaxone with vancomycin, depending on the bug, and you have to give for prolonged period. Then coming to this is very important aspect is what is rational antibiotic combinations, whether you should use combinations or whether those are rational. So I'm not talking about the combinations which are there in the market. So it is beyond scope to discuss each and every combinations, but sometimes you have to use antibiotic combination in a rational way. Why we should use? First and foremost use is for synergistic activity against microorganisms. Like for Enterococcus endocarditis, we are using penicillin and gentamicin, so they act synergistic. Then in critically ill patient as an empirical therapy before microbiological etiology is not available in form of septic shock against. So you have to use cover for both gram-positive and gram-negative organism. Third thing is for treatment of polymicrobial infection like intra-abdominal infections, brain abscess, necrotizing fasciitis, where you are using third generation cephalosporin or quinolone with metronidazole. And the fourth, sometimes the purpose is to prevent the emergence of resistance, like using in what we use in anti-cox therapy or highly active antiretroviral therapy. The purpose is because you are giving for a very prolonged period, you need to give for this is you have to give as a combination therapy. So important question is why do antibiotic fail? So antibiotic fail rather than resistance, there are quite common causes like whenever there is collection of pus like empyema or subdural collection, which there is a foreign body, non-resolving recurrent pneumonias are there, or you have a necrotic tissue like polytrauma, Stevens-Johnson syndrome, toxic epidermal necrolysis, burns, staphylococcal scarlet-Sinn syndrome, where the necrotic tissue is there, unless and remove it, your antibiotic is not going to act. Or you are hitting a different organism like mycoplasma, TB, viral leptospirosis, rickettsia, or fungal. That means you are not dealing with the bacterial infections, or you are dealing with the atypical atypical organism. Or you can have an improper diagnosis. That means you are not dealing with infectious cause like Kawasaki disease, where everything looks like fever, but everything looks like bacterial infection, but it is ideally immune disorder. Now coming to the concept of de-escalation, antibiotic de-escalation. So this is very much important concept, and unless and until we are knowing this, so that's why. So what is de-escalation? Reassessment of treatment when culture results are available. Generally incorporates in a reduction in the spectrum of administered antibiotics either by discontinuation of antibiotic or switching to agent with narrowing spectrum. So this is very important. Even if you have started 1 or 2 antibiotics with high spectrum, once the antibiotic sensitivity reports come, then you have to you have to discontinue which is not sensitive for that particular organism, or then you have to narrow down the spectrum. So once the pathology is identified, empirical antibiotic should be stopped or reduced to number or narrow down the spectrum. And why this is important is this strategy is capable of promoting therapeutic appropriateness, averting the antimicrobial resistance, reducing the toxicity, and reducing the cost. So this is very, very important concept of antibiotic, rational antibiotic therapy. Then rational antibiotic therapy concept doesn't complete without discussing antimicrobial stewardship. So what is antimicrobial stewardship? I will not go in details of stewardship, just I will touch this fact. This antimicrobial stewardship is a coordinated program that promotes appropriate use of antimicrobials, including antibiotics, improves patient outcome, reduces microbial resistance, and decreases the spread of infection because of multi-organ resistant bugs. So what are the core elements? Leadership commitment is required, accountability is patient quality focused, then drug expertise, appointing a single pharmacist leader, taking action like pre-authorization of antibiotic and antibiotic timeout after 48 hours. Tracking, so it is monitoring the process, adherence to the facility specific guidelines, time to initiate or de-escalation. So very important is tracking. Sixth core element is reporting. Report the above information regularly to doctor, nurses, and relevant staff and take their feedback. And last but not least is the education. Educate clinicians about disease state management, resistance, and optimal prescribing. So this, whatever CME or lecture is there, is very important part of antimicrobial stewardship program. So coming to last part of my lecture is what are the take home messages from today's lecture. So first and foremost is try to obtain an accurate microbial diagnosis. Second is prescribe an antibiotic when it is absolutely needed. That is in the presence of true bacterial infections. This is very, very important. Is we should not put for most non-viral infections. Then always prescribe first line, possible narrowest spectrum of antibiotic for optimum duration and optimum dosages. All things are important. Narrow spectrum, optimum duration, and optimum dosages. Assess the response and look for the side effect of antibiotic. Avoid overuse of antibiotics or irrational combinations. In case of non-response, look for the compliance, complications, and alternative diagnosis. So as I already discussed about what are the non-response causes of non-response. Do not use antibiotic in non-bacterial conditions. So majority of the pediatric infections, around 7 to 80% who are coming to OPD are because of viral origin, and where antibiotics are not needed and you should not prescribe. Developing the culture of culture. So culture of culture means try to send cultures, put faith in your microbiologist, and that will help you not only for you in long run, but for the patient over the period of time. In healthcare associated infections, start broad spectrum and de-escalate and revise the regime as per culture sensitivity reports. Observe infection control measures. This is the most important thing, and hand hygiene is the cheapest and most cost effective measure to treat the infection control. Then improving the vaccination coverage, try to establish microbial diagnosis by other point of care non-culture methods. And last is self-audit your antibiotic uses. I think this is what I have discussed about rational antibiotic therapy points in pediatric age group. But though I have talked diseases of pediatric age group, these principles of rational antibiotic use are principles that can be applied, or they are usually applied for adult population also. Then last part is Mission AAA. This is a Indian Academy of Pediatrics, and we have started with IMA. This is Mission A, that is called as Avoid Antibiotic Abuse, and this is the most important point about once even you can, if you can remember this slide for you is very important. This is a Rational Antibiotic Day. We are celebrating on 20th September. And we are celebrating Antibiotic Awareness Week from 20th September to October 5 every year. So to conclude my lecture, save antibiotics today so that antibiotics would save you for tomorrow. I really thank IMA Sangli for giving me this opportunity to talk on a very important subject of antibiotics, rational use of antibiotics in pediatrics. Thank you. Thank you very much.
I thank Dr. Patki for a lucid presentation. May I request today's distinguished speaker, Dr. Rahul Pandit, to deliver his speech on antimicrobials in critical care. Dr. Rahul Pandit is an intensive care consultant. He is the Director of Intensive Care at Fortis Hospital, Mumbai. He is a National Task Force member appointed by Supreme Court of India and Maharashtra Task Force member as well. He is a visiting ICU consultant at hospitals in Australia. He is a teacher for DNB Critical Care and College of Intensive Care Medicine. He has several publications on his name. He has delivered hundreds of lectures and scientific presentations. His special interest in critical care, echocardiography and ultrasound, brain trauma, organ donation, and COVID-19. Dr. Rahul Pandit has done MD in anesthesia at Grand Medical College and JJ Hospital, Mumbai. He has prestigious fellowship of Australian College of Intensive Care and worked as consultant in Australia for several years. He has European Diploma in Intensive Care Medicine. Being recognized for his contribution in this field, American College of Chest Physicians has conferred upon him Fellowship of College of Chest Physicians. Now I welcome Dr. Rahul Pandit.
Good afternoon, friends. Today, for the next 20 minutes, I'm going to talk about antimicrobial and its use in intensive care unit. I think the most important thing to understand about antimicrobials in ICU is how do we rationally use it? How are we going to rationally use the antibiotics which are available to us? Where are we placed currently in terms of antimicrobials and the way ahead? Dr. Malani has already covered very nicely the different antimicrobials which are currently being used in the intensive care most commonly. Of course, you will have some outliers there, but that should not bother us because these outliers are rarely used in the intensive care unit. You would have the more common drugs, and those are the ones which we actually need to know completely in and out about. So let's start off with a case. I always like to start off with a case. We've got a 53-year-old diabetic who's got 2 or 3 episodes of urinary tract infection in past. Went for a trip to Somnath, had fever, dysuria, was treated with non-steroidals and aminoglycosides for 3 days. And then patient returned back to Mumbai. And upon coming back, patient developed anuria and developed acute renal failure. Was admitted, was catheterized, but catheter was removed after 2 days. Blood and urine culture were sent for culture and sensitivity. So that's the case to begin with. You can show that, you can see that emphysematous pyelonephritis, which was seen in the CT scan. Here you can see the left kidney being completely emphysematous and distorted, and hence was shifted to us. And the treatment started was fluconazole and meropenem. So from the 4 things, what should not have been done? Should we not be sending blood cultures? Should we not be starting fluconazole? Would a DJ stenting be required? Or should we not be starting meropenem? I think if you ask me, apart from the second option, all the other options are correct. You need to send a blood culture. You need to send you need to do a DJ stenting to try and drain out the pus. If you can, sometimes these patients even require a nephrectomy. And of course, you need to start meropenem. And why is that? Let's come up to the clinical challenges which we face quite often in intensive care. The problem is that antimicrobial resistance has become a serious public health issue. And it's not just limited to that, it's become a social implication throughout the world as well. It has often led to higher hospitalizations, longer stay in the hospitals, and the treatment costs are escalating. And very often it is associated with a poor outcome. That's the big problem. In spite of doing a longer hospitalization and more cost, the outcomes are not very good. And it is a misuse, I would say, not the overuse, the misuse of antibiotic, which is a problem. If you look at all hospitalized patients, approximately 30 to 50% in US, and I think 70 to 90% in India receive an antibiotic. And if you actually go and audit, and we did that audit in Fortis as well, and we found that half of the antibiotics were unnecessary, were poorly chosen, or had an incorrect dose. And physicians and surgeons often chose broader spectrum instead of narrow spectrum antibiotics for reasons best known to them. And the problem was that with this escalating antibiotic, we could see the escalating graph of our antimicrobial resistance as well. So we did around 5 years back, we did a very important audit and we restricted antibiotics. And my friends, almost 2.5 years until COVID came, we had not one case of Acinetobacter in our hospital. But COVID came and everything went for a toss. And the environmental bacteria came up, the non-fermenters came up, and we started seeing Acinetobacter again. Then the Infectious Disease of America, the Infectious Disease Society of America, talks about this escape group of antibiotics: Enterococcus, Staphylococcus, Klebsiella, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter coaci. These are the 6 bugs which carry a mortality as high as 75%. And you need to treat them, and you need to treat them right. The 2 gram positive, the Enterococcus, the Staph aureus, and then you've got a Klebsiella, the Enterobacteria, and then you've got the non-fermented bacteria as well. So we need to be clear what kind of syndromic approach are we going to take up in managing these patients. To top it up all, we know that from 1910 to now 2020, there has been no new group of antibiotics which have come out. What we see is if I could call it in layman's term, a distant cousin of the same group of antibiotics. And it really just changes a little bit of a side chain and gives you a bit more penetration. And we all start thinking that this is a better antibiotic to use. The road ahead is very, very difficult. And we need to be aware that superbugs are causing a lot of problems for us. What's the Indian scenario? If you look at this study was essentially looking at prevalence of methicillin resistance. And they saw that almost 40% of patients in a particular isolate in a tertiary care unit were showing Staph aureus. This was a study which was done in the eastern side of the country. Does not actually show and depict anywhere else in the country that we actually see these gram-positive organisms a bit. So what does our country show? Our country shows almost 40 to 60% of ESBL producing E. coli and Klebsiella. We have a significant resistance to cefotaxime, piperacillin tazobactam, but a increasingly more resistance to carbapenem as well, which is what is the worry. And there is a complete temporal relationship between resistance and consumption of antibiotic. If you look at the total number of isolates in this study, which was published in the Journal of Clinical and Diagnostic Research way back in 2013, you can see that ESBL producer was the highest culprit, 35%, followed by MBL or a CM, or a combination of either of them. And they really were down to say 10%, 5%, 8%, 7%. And E. coli seemed to be the biggest culprit along with the Klebsiella. So we need to be really clear that even in the rural tertiary care units, we are seeing a lot of resistance in the antibiotics. The Indian context, if you look at the OXA48 class, which are sort of emerging now in Enterobacteria, they are peculiar because they are weakly hydrolyzed carbapenems, and the weakly hydrolyzed carbapenems and the broad spectrum cephalosporins. and they're difficult to identify. And unfortunately, we just don't know the exact incidence of it. Though we know that India stands to be very, very high in OXA 48 class of drugs as well. This one study from Haryana and Amritsar, Haryana and Amrita Institute actually again shows that a significant amount of antibiotic resistance is seen in gram-negative infection. So this cartoon actually talks quite nicely about the relationship of antibiotic and resistance. And it's increasingly becoming a multifaceted problem. And it's important that we actually do a balancing act so that the patient receives the right treatment. At the same time, we are responsible enough to not increase the resistance. Let's look at some of the inadequate therapies in critical care unit patients with serious infections. The myth is that the time to start with one therapy and then escalate if needed. This used to be the thought process before. The fact is that inadequate initial antimicrobial therapy actually increases mortality. And changing from inadequate to appropriate therapy may not decrease the mortality if you do it late. Whereas the initial delay in starting an inappropriate antibiotic therapy is an inadequate therapy, and it basically gives rise to a significant amount of mortality. So we need to get it right the first time, otherwise you're going to land up with patients in mortuary. So if you have patients who are infected, and if you started inappropriate therapy to them, you would see that the relative risk of death increased by almost 2.5 folds. Whereas if you gave appropriate therapy, it was much less, 42% versus 17.7%. So we really need to understand that what are the bad habits that we have with antibiotic usage. So one of the poorest habit we have, and unfortunately I think it still is prevalent, is that we start antibiotics before culture. There are only 2 indications to start antibiotic before culture. One is meningitis and the other is a community acquired pneumonia, because taking cultures are very difficult from these site specific things. Rest everything else, a urine, a blood culture, a pus culture, is very, very easy. We are also poor in initiating antibiotic therapy based on a syndromic approach. Is this a central line related infection? Is this a chest related infection? Is it a community acquired? Is it a hospital acquired? I very often see that patient is admitted in the hospital for almost a month, and then the physician wants to start them on clarithromycin or azithromycin. For what? Are we going to get Legionnaire's disease in the ICU? Very unlikely. What's going to happen probably is that this patient has a gram-negative, and clarithromycin and azithromycin may actually have a very poor cover for that particular hospital-acquired gram-negative bug. The third thing is that despite knowing our local antibiogram, we fail to apply that knowledge to the bedside. When we get results back of gram stain and cultures, we do not want to change the winning combination and thereby promote blood culture resistance, organism resistance. And then we continue antibiotics for an inappropriately long time. We also have some problems that when IV treatment is as effective as oral treatment, we don't change to oral treatment, we continue with IV treatment. Another problem is patient has a creatinine of 2, the first dose itself is tapered down. The initial dose has to be a full dose, and later you have to adjust the renal or hepatic function. When required, we do not actually consult to ID specialist. Broad spectrum antibiotics are given when a more restrictive spectrum may be just as effective, and combination therapy is used very often without a logical justification for its use. And all of these just influence into a reasonable amount of colonization and infection and resistance to it. Some of the facility level factors like hand washing, gloves, masking, I think COVID has appropriately taught us those things, but we're still not really realizing it to the full potential. So what are the risks of developing an MDR pathogen? Antibiotics in previous 90 days, hospitalization for more than 2 days in the last 3 months, home therapy where antibiotics are given, chronic dialysis, immunosuppressive therapy, so on and so forth. So we need to hit it right when we are in the intensive care so that we can actually get them correctly in the first time itself. So what are the key features of this? We need to consider the following when we determine an appropriate therapy. What's the spectrum of activity? What is my dosage and frequency going to be? Now, that's a very important one. In dosage and frequency, we know that there is a increased volume of distribution, especially on patients who are on CRRT or who are on dialysis or on sepsis. We are giving them large volumes of fluid. We need to consider them that they need to be given full drugs, full volumes. And times we actually underdose them because of kidney or liver function. And then on top of that, with their high volume of distribution, the dosage actually further reduces down. You need to be able to monitor drug levels where required. You should have a potential for selecting antibiotics during resistance patterns. Your timing and duration should be correct. Your drug interactions and tolerability for other drugs has to be checked. And most importantly, you need to know what prior antibiotic therapy was this patient given. Once you have that, then you need to consider some other factors. Microbiological data. Am I going to use a monotherapy or a combination therapy? What is the tissue which I am using? One of the commonest thing which I see is gram-negative organism XYZ been reported in the urine and tigecycline been given as a sensitive drug. Yes, the drug bug may be sensitive to tigecycline, but the tigecycline does not have a urinary tract infection, urinary tract penetration. How are you actually going to get that drug into the urinary system? Then you need to also look for prior use of antibiotic and hemodynamic stability. In the current use, I think we need to go beyond just that understanding. We need to have an application of PKPD. We need to understand the risk factors of the presence of MDR pathogens. We need to be able to do antimicrobial stewardship program. You should be able to escalate and de-escalate therapy based on evidence. An appropriate duration should be given, and infection control is very, very important. I think de-escalate, the more you emphasize about it, it is less. Ordinarily, once the infection is controlled and de-escalation is advised, empiric therapy should stop and give way to definitive therapy based on culture sensitivity report. And there is enough data to show that outcome actually improves with this. Another thing is we need to understand that the ancillary things like hand washing, barrier precautions, nursing staff, medical staff education, medical staff leadership, all of this makes a difference as well. If you look at some of the ITSA guidelines, it says that you need to have a selection of optimal antimicrobial agent, route of administration, dose, and duration to provide maximal clinical benefits while minimizing unintended consequences. It has got a central role in any infection control program. It should be driven by either ID specialist or intensivist and a clinical pharmacist with infectious disease training, and other members of the team should be there, like microbiologists, infection system, information system specialists, infection control nurses, infection control professionals, and of course, you need to have hospital epidemiologists as well. Then you need to have a prospective audit with interventional feedback, formulary restriction, and pre-authorization. The other ITSA guideline says parenteral to oral conversion. When patient's condition allows, decrease the length of stay, decrease hospital costs by changing from parenteral to oral, and development of clinical criteria and guidelines which allows the use of oral drugs. Similarly, you need to de-escalate drugs when it's not required, when the culture therapy has been abundantly treated and makes almost a redundant cause to continue with the same antibiotic. And you need to do that based on the PKPD dosage. It needs to be done on the PKPD parameters and, of course, the tissue penetration. It is very important to have educational programs and active interventions to provide a foundation of knowledge to all the staff. And clinical pathways are important, and you need to incorporate local antimicrobial flora patterns and provide education and feedback to the clinician so that they understand that this is our flora and this is what we need to treat. Combination therapy, there is insufficient data to routinely use combination therapy. It has a role to increase coverage in empiric therapy in patients who have multi-drug resistant pathogen risk, but not in anybody else. Another thing, procalcitonin. Is it smart? Is it a smart antimicrobial therapy starter or a stopper? Well, we want a test to be specific and sensitive. It is specific and sensitive, measurable, available, and affordable. It's not really affordable. It is responsive and reproductive and results in a timely fashion. Well, word of caution, there are other things which give rise to a high procalcitonin, like newborn, primary inflammatory syndromes like trauma, burns, major surgery, cancers like thyroid, pulmonary cancers, prolonged circulatory failures like cardiogenic shock, hemorrhagic shock, and treatments that can cause cytokine storm, like a COVID-19 cytokine storm. It's not like Rajnikant that everybody can use procalcitonin and get away with it. I think the role of procalcitonin exactly is actually stopping the antimicrobials. And here you can see in this one study, the procalcitonin group used lesser antibiotics as compared to the control group. Nevertheless, antibiotics kept on going down, but did go down to almost almost 21 days. In summary, my friends, I think it's more difficult than ever to eradicate infection caused by antibiotic resistance and superbugs. The problem is exacerbated by dry pipelines for new antimicrobials. A concrete effort on part of clinicians, institute, industry, pharma industry, government is required to actually maintain upper hand in this battle against bacteria. And we need to fight the global consequences as well. These are some of the mechanisms through which the organism develop resistance. I don't want to go into a lot of details of these, but I think there is enough to actually talk about right now. I'll be happy to take questions if any. Thank you very much.
So, Dr. Malani,
Yes.
so we are having rampant use of antibiotics, and there is no regulation for the use of antibiotics. So over the counter, there are so many antibiotics which are actually we can get. So do you think that government regulations are necessary for this regulation of antibiotics to prevent this emergence of antibiotic resistance and misuse of the antibiotics?
There has to be tight control for antibiotic usage. Certain antibiotics, especially higher antibiotics, should not be available without a proper doctor's prescription. It's an absolute requirement to reduce antimicrobial resistance.
Yes, so there should be, I think, government guidelines which should be telling which, like if we want to give antibiotics, there should be a proper prescription from a clinician side. So many times what we, as in your lecture also already you have mentioned if somebody wants some higher antibiotic, even like piperacillin, tazobactam or meropenem, so they just take a chit and the pharmacists give them that antibiotic. So I think this practice should be discontinued and there should be some government regulations in this.
Yes, absolutely.
Yeah, so my next question is to Chidgupkar madam. Madam is there?
I'm there.
So, madam, do you think that there should be a dialogue between a clinician and a microbiologist whenever we start to we need to start some higher antibiotic or we are treating some critical patients? So, do you think that there should be a communication between the clinician and the microbiologist?
Yes, absolutely. Piyush, will you please start my video? Piyush? Host has blocked my video. Anyways, I'll start giving the answer. Actually, all of our speakers have already stressed on the importance of microbiology during the antibiotic therapy. So we have already heard about this, but still it is very necessary to have dialogue between physicians and microbiologists. Actually, the basic golden rule for antimicrobial prescription, we can say it is mind me. What is M? It is microbiology guidance therapy whenever possible. Then indications should be evidence-based, narrowed spectrum requirement, then dosage appropriate to the site and type of infection, then minimize the duration of the therapy and ensure monotherapy in most cases. So at each step, we require the microbiological assistance. And the most important thing is to know the organogram of that particular hospital or area or community, as well as to know the antibiogram, so that we can start empirical therapy and then switch over to the broad spectrum or narrow spectrum proper antibiotics. So it is very necessary to have dialogue between with the microbiologist.
Thank you, madam. Very nicely answered.
Thank you.
My next question is to Dr. Vinayak Patki.
Hello, Mr. Piyush, can you start the videos of the panelists?
No, I haven't blocked anybody.
No, nobody is seen.
No, all are seen, madam.
Yeah, I'm sending a request to start video. Please click on yes.
Okay.
Yeah, please continue.
My next question is to Dr. Vinayak Patki. It is a very practical question. In your lecture, you said that we get a lot of respiratory infections because of viral infections, and we don't need any antibiotics initially. But actually, what we see that if you don't give antibiotic, within 2 to 3 days, the patient does not respond. And then after 2 to 3 days, when we add antibiotic, the patient responds well. This also happens in indoor patients. So how do you explain this?
Thank you, Dr. Geetanjali, for the nice question. It is a common phenomenon observed because most of the times, both parents as well as treating doctors are in a hurry to start the therapy of antibiotics. Nobody is ready to wait. As already in my lecture, I differentiated between viral and bacterial infections. Usually the viral infection, the fever starts disappearing by 3rd or 4th day or maximum 4th to 5th day. We always, because 2 to 3 days, if fever doesn't subside, most of the times parents of now single or two-child mom, they become apprehensive and they are literally forcing the pediatricians to start antibiotic. This is what's my experience is. And your question is, why do they respond immediately after starting antibiotic? Is nothing but it's just a coincidence. Your antibiotic is not acting at that particular time to kill that virus, but it is a natural phenomenon of that viral disease itself, that just that 3rd or 4th day, you start antibiotic on 3rd, 4th day and just fever subsides. So most of the times it is a coincidence. It doesn't, though antibiotic has proven antiviral activity. And that's how the broad message from this panel we want to give to both parents, doctors, and they should percolate this message to the parents that we have to wait. If child is not toxic, interfebrile period is quite okay, they are stable, eating well and all, you should not be worried, you should not be in hurry to start the antibiotics. And that is the main answer for this question.
My next question is to Dr. Rahul Pandit. Is it necessary to give antibiotics in each and every patient at getting admitted to the ICU at the beginning itself?
Of course not. There is no need to give any antibiotic to most patients. You give antibiotic to treat infection. There is no preventive antibiotics to be given. The only reason people get antibiotic preemptively would be for patients who go in for a surgery, which is actually a surgical prophylaxis, which is to be given within the 1 hour of the surgical operation, and the surgery should be commenced. Otherwise, unless there is an infection suspected or infection being treated, there is no need to give any antibiotics.
Thank you very much, Dr. Pandit.
Thank you, sir. My question actually goes to all panelists, that many times when a patient is admitted with us with a severe infection and we start some antibiotic, and actually we send the blood cultures or some other culture and other reports. So patient actually starts responding to that antibiotic. And then we get the culture report and the culture is showing that there is a resistance to that particular antibiotic. So should we need to change? Actually, sir, Pandit sir, you have covered this, but I want to have more elaboration on this topic. Whether we have a need to change the antibiotic depending upon culture results.
May I answer first, being it related to culture? Thank you very much. Actually, when I'll again go to sampling. That's why I stressed on the specimen collection and sampling. It is very necessary to collect the proper sample from proper site, and which should not be contaminated. So many a time it happens, the number of samples, proper site of sample is not catched, and in that case we may grow contaminants or commensal flora, and we get the sensitivity out of that, which is not a proper, because many a time ICU contaminants or even community contaminants nowadays are resistant to certain antibiotics. So we have to know actually which organism which have been isolated, it has really causative or etiological role in that particular infection, and then we should start interpreting. Thank you. You can go ahead with other speakers.
So, Pandit sir,
Yeah,
can you
so
elaborate?
I think there are three things in this, madam. The first thing is how you collect the culture. So specifically for blood culture and urine culture, often the required amount of finesse is not used. So many times they would actually collect the urine from the catheter tubing, which is going to give you a contaminant. So you need to collect the urine, which is either coming directly without a catheter from the patient, or if the patient is catheterized, then you need to collect it from the Foley's catheter, not from the catheter tube, the bag tubing, which becomes a problem. The second is blood culture. You need to treat blood culture collection as an aseptic procedure. So you need to scrub up, you need to have a complete sterile precaution. And remember, all of these are inoculum dependent. So you need to send good volume of blood culture. You need to send at least 20 mils of blood culture, so that the microbiologist will be able to determine which is the growth and which are contaminants. With the inoculum dependence, they'll be able to tell that this seems to be a very heavy growth of a particular organism. The second point is that whatever culture report comes back, it should be corroborated with your clinical findings. Okay, that is the most important thing. If a culture report comes and you are treating, let's say you are treating a bad pneumonia, which is a community acquired pneumonia, and you get a weird culture, you need to question yourself and start thinking that why am I going to treat this blood culture when my problem is actually pneumonia and it is not sort of matching into it. So that's the second thing which we need to understand. And the third thing we need to understand is that after all, some of these antibiotics which you have started, and they may not show a good resistant pattern, will have some subclinical effect, which we often perceive. And as Dr. Patki said, that sometimes patients does tend to improve as well. And we start perceiving that the patient is actually stabilizing, which may not be the case. It might be a short-lived phenomena. So if culture is indeed true and your clinical picture is matching, then it is always necessary that you collaborate. That's why the dialogue with the microbiologist is important. And then you go ahead and treat the patient. So these are some of the things which we need to cover up, just not the fact that culture has come, so I'm going to change as per the culture. Whether the culture actually matches with the clinical picture or not is also very important.
Yes, thank you very much.
Like the case which I showed, madam, the Candida glabrata was of no meaning in a urine. At that time, the main problem was that this patient had a gram negative. He had gangrene in his kidney, and if we would have started treating him with fungal infection, we would have probably missed out on the whole problem. So I think that's where we need to understand that, are we really getting a right culture or not?
Yes, sir, very true, sir. Because many times we get carried away by the culture reports, and actually our patient is responding to a particular group of antibiotics. So I think clinically, microbiologically, we have to judge and then decide about whether to change the drug or not to change the drug.
Another thing, if I may add, madam, with your kind permission,
yes,
is winning combinations. Many times we get carried away by saying that this is a winning combination. It looks like it's working, so I will not de-escalate, which is also a wrong practice. So if you have a clearly culture showing that you have a lower group of antibiotic which is sensitive, or you have a monotherapy which will be required, which will be enough, you please go for that. I mean, you need to be, you should be able to change up or down based on the culture. That's why the culture is important. And once you have that information, we need to act on the information. Otherwise, it's a waste of time. If you're not going to act on the culture information, then it's a waste of time completely.
Yes.
And secondly, the microbiology laboratory you are choosing should also be following absolutely standards of performance. They should be in QC, must be followed properly, and all the standards must be followed properly. That is very important to get the proper yield of the microbes also.
One line what I want to add, always the principle is treat the patient and not the report.
Yes, yes.
I think this is the most important thing what my postgraduate teachers and stalwarts in, not in pediatric ICU care, but so this how you have to interpret the whole situation, whole scenario or the clinical background, and finally we have to treat the patient. So all these factors what Pandit sir and madam has told, this is very collaborative and we have to take a big picture rather than seeing through a small window. We have to see the big picture. So.
Yes, sir. Thank you very much. My next question is to Dr. Malani. Actually, we are not talking here about anything about tuberculosis, but as many cases we are getting MDR TB nowadays very prevalent. So do you think that any antibiotics which are used as a second line anti-tuberculous drug, they need to be preserved? We should not use in our routine practice as an antibiotic.
Yes, absolutely. Moxifloxacin and linezolid are two antibiotics which are very commonly and rampantly used for some minor indications. So this is a misuse of these antibiotics, which are also second-line anti-TB drugs. The misuse of these drugs should be avoided.
Yes. So I think for routine practice, we should avoid these antibiotics,
yes,
and we
absolutely.
should reserve them for use as an anti-tuberculous or even for MDR resist organisms also.
Certainly.
Geetanjali.
Next question is to Dr. Patki. Why is the duration of different antibiotics different in conditions, but the microorganisms is the same? For example, duration of antibiotics in ASOM, pneumonia, meningitis, or osteomyelitis is different, but the organism is same. Why is it so?
Two important things are there. First and foremost is what is the site of infection. This is like very important, like upper respiratory infections or lungs. There is a very good amount of penetration of the antibiotics and then reach there in the proper way. But a problem happens with CSF penetration as well as deep-seated abscess or osteoarticular infections, where they cannot able to achieve the MIC whatever there is expected to achieve. And that's why even if we consider this example like for staph. So staph we consider say for acute otitis media U for 2 weeks, 2 to 3 weeks, and like complicated kind of thing. And for meningitis and all this, we give it for a long period. That's why they achieve the concentration more, the penetration is more. That's why same organism, the site does matter, as it is comparing to the one important thing I already discussed, penetration and achieving the MIC for a longer time, because they are getting it in a very deep-seated infections. That's why the dosage importance. Again, an immunocompetent patient and immunocompromised patient, again the dosage duration will be different. That's it, the basic reason for treating this for long or short time.
Thank you, sir.
Thank you so much.
One question we had in a chat box related to pancreatitis, that for pancreatitis, actually antibiotics are not required. But in which condition we should start antibiotics in pancreatitis, and which is the antibiotic of choice in case of pancreatitis?
So I can take that question if it's okay.
Yes, sir.
Yeah. So the question is absolutely correct. You don't require antibiotics for pancreatitis. So the clear indications for treating infection in pancreatitis is if you have a fine needle aspiration of the fluid of the pancreatic fluid being taken out through a interventional radiology, and that grows some organism, then you treat as per the specific ones. The antibiotic of choice has most of the studies have been done on carbapenem group, which is imipenem. There are some studies which have looked at piperacillin tazobactam as well, but the penetration of carbapenem has been the best. So many people usually tend to start straight away with carbapenem, which is a problem because then you start developing resistance to other organisms very, very quickly. So unless and until there is a clear culture or a clear second or third week progression which has worsened, please do not start antibiotics in pancreatitis. That is simple as that. The only exception to that would be that in the first week itself, there was a pancreatitis secondary to gallstones, and then the patient has landed up with a cholangitis. That would be one of the exceptions where you would want to start the antibiotics early. And that obviously needs to be discussed on a clinical scenario and a call taken up for that. Otherwise, usually first 7 to 10 days, no antibiotics for pancreatitis is required.
Thanks. Geetanjali.
The next question is to Dr. Pandit. Generally, when we see patients in ICU, we see that the patient is on antibiotics, about 3 to 4 antibiotics are seen in a patient. Is it really required to give 3, 4? Can there be a protocol for antibiotic usage in ICU?
So we all are guilty of misusing antibiotics. I'll tell you the scenario around 4 months ago in our hospital. We were a major referral center, and I had some of the bacteria which, I find it even now difficult to pronounce and speak. Chrysobacteria, and they were all multi-drug resistant. Jyoti madam is smiling. I mean, she would be able to tell all the bacteria. I would not be able to tell even the name of half of them. But for those multi-drug resistant bacteria, we had to use a combination of 2 or 3 drugs at a time because they were just not responding. And these were the bacteria which came out. I mean, I am sure they came from some of the patients who were referred to us from outside. And then they made our ICU their home. And we had a small outbreak of patients at that particular time where 7-8 patients in the ICU quickly got infected with that. So we had to use a combination of 2 or 3 gram-negative agents to try and cope up with this. Right now, even let us say we don't have such a unusual bacterial outbreak, but for a multi-drug resistant gram-negative right now, we are still using 2 antibiotics, one carbapenem and colistin for a hospital-acquired infection. So 2 antibiotics are anyways going in right now. So just monotherapy with colistin is not helping. Just monotherapy with carbapenem is completely ineffective. So we are already into an era where combination therapy for hospital-acquired superbugs is becoming a problem. And on top of that, when you have these pan-resistant bugs, it is a combination of 2 or 3 drugs which is required. But I completely take your point that my other half of the practice, which I do for 3 or 4 weeks in a year in Australia, if I have to prescribe anything more than ceftriaxone, I have to take ID clearance. I'm allowed to give 1 dose in the intensive care, and I have to speak with a local infectious disease person, discuss the case with him. He or she would discuss the case with me, would find a merit in it, and then go ahead with the prescription of a higher antibiotic, which could be a piperacillin tazobactam or a cephalosporin sulbactam or a carbapenem or whatever. So that kind of a shouldering of responsibility, if it is there, we will never allow these bugs to come across. The problem is that when we work in a tertiary care unit, we are at the mercy of what is coming in through our front door because there is no control on antibiotics before that. We all must have discussed this, that antibiotics are even prescribed freely by GPs. General practitioners are giving peptides infusions in their clinic, which is a problem. Okay, so I think there is no point in somebody asked a question to Dr. Malani that should there be a restricted antibiotic policy by the government. It is already there, madam. We are not following it.
Actually,
the prescription is not being honored in such a way that the pharmacists don't feel that it needs to be honored. Unless there is a prescription, I will not give a drug. Secondly, who is prescribing also needs to be looked at. So certain degree of you would give privileges to certain people to prescribe these antibiotics, like the Australian example, that unless there is a privilege by infectious disease specialists, the certain degree of antibiotic will not be prescribed. We are far away from that reality, very, very far from that reality. So we need to be aware that we will have these kind of conundrums in front of us on and off, and we will have to gently tread our way through.
yes, sir.
Very
At
correct.
least we should start auditing our prescription in our own clinics. That will also help us a lot, I think.
Actually, at institution level, we are having all these audits and everyone, but at local practitioner level, we don't have these audits. So that is why I think there is a big problem, because you cannot challenge anyone if somebody is writing one antibiotic or the other antibiotic. Many times we are seeing this problem that half-hearted dose is given for 2 to 3 days. Again, there is a change. And when the patient becomes complicated, then the patient is being referred to some institute. So that is why the people who are working in intensive care units, they face a lot of problem for this antibiotic resistance.
So Dr. Malani was with me 3-4 weeks, a couple of months ago, and he knows the practice in our ICU. He had come visiting me as a friend. Without justification of an antibiotic, even we have put the similar sort of a process. Our infectious disease specialist has to write, or if infectious disease specialist is prescribing, then I have to write that this is an appropriate use of antibiotic. So we have to actually write down a form. The form talks about appropriateness of antibiotic use, and that antibiotic use is then given permission by the counter signature by the other colleague. Only then we go ahead. What happens with that is we found out that moment you ask somebody to justify an antibiotic, prescribing an antibiotic is one thing, but if you say to them that you write in the notes, what is the justification for use of these antibiotics? 30 to 40% of them say, Raude Magata Udya Bogya. Let us see. Tomorrow we will see. They back off the moment you ask them to write a justification. Then you know that this was a very soft indication for it anyway. The 60% who do go across and then write, then have to justify it to the microbiologist. And yeah, many times it might be appropriate as well. We are not there to cross off antibiotics. We are there to just support the use in the right way.
Yes, sir. So this question, like continuing with the same with Dr. Malani, like what are the red flag signs if we are practicing, but what are the red flag signs where actually antibiotics need to be start immediately? Otherwise, if we delay, the patient may land up in sepsis.
As I already talked in my speech, there are signs of witch fever bacterial infection.
Yeah.
Fever with chills and rigors. There are localizing signs. Patient may complain of pain at a particular site, like right fossa pain in case of appendicitis, right hypochondriac pain in case of gallbladder infection. So these are the important signs, localizing signs. Besides, CBC has become a very, very important investigation. Simple CBC can guide you when to start an antibiotic. Gross shift to left, gross increase in count, band forms, toxic results in WBCs are one of the few indications to start antibiotics. And always you have to correlate clinically. Patients parameters, focus of infection, lab parameters, and then X-ray ultrasound and all investigations. They will point it out whether it is infection is bacterial or non-bacterial. So depending on all these things, you have to correlate clinically and start antibiotics.
Thank you, sir. Now, all of us are facing COVID. So many questions are related with the COVID to all the clinicians, like which are the antibiotics which we should actually start in a COVID scenario. So as such, as I know that COVID as such is a viral infection. So in mild cases, I think there is no need to start antibiotic, but still there is a practice to start doxycycline, azithromycin when the patient comes COVID positive with mild symptoms. So what is your opinion about that?
There should be no antibiotic prescribed, madam. Absolutely not. Even in severe cases, unless there is a concurrent secondary infection, there is no rule for prescribing antibiotic. Absolutely. And secondary infection, usually we start seeing after 7 to 10 days. It doesn't happen in the first 7 days. Yes. So first 7 to 8 days, it's all COVID and it's all viral phase. We all know the phases now. It's been 2 years. We all have been looking at those graphs quite regularly. So we don't need to repeat that. But after 7 to 10 days, if you think there's a secondary infection, if you suspect it strongly or you prove it on the culture, then yes, they would require antibiotic. Just one more thing to add what you spoke with Dr. Malani. There is something called the Q-SOFA score, quick SOFA score. The Q-SOFA score is for patients who present to emergency department, or more importantly, who are actually admitted to the ward, whether they need to be shifted to a higher care, like high dependency unit or ICU. Just 3 signs: level of consciousness, heart rate, and respirator, blood pressure and respiratory rate are good enough to tell us whether this patient is going to require a higher care or not. And usually these 3 signs correlate quite well with a total SOFA score, which is a sepsis score. So that would be another reason I would start. If the Q-SOFA score is 2 or more, I would probably give them an empiric antibiotic at that time and then shift them to ICU if there is a suspicion of an infection. Of course, if there is a clear alternate diagnosis like a stroke or something because of which the level of consciousness is low, then we will not give an antibiotic.
Yes, sir. Many people in chat box, they have asked Pandit sir to share the form which they are using. I think antibiotic justification form.
Anand,
We are actually using
I will share.
in Bharti.
Yeah.
We can share actually. So antibiotic justification form, we are also regularly filling that justification forms. So I think we can share that on the group. And just one simple question to Dr. Malani, like you said, many times we get a reaction, anaphylactic reaction. And before that, means before starting any antibiotic, IV antibiotic, we should go for a test dose. So can you please elaborate how you perform it in your routine practice?
First is about history. If there is history of allergy to any drug, you have to be very, very careful. Any beta-lactams or penicillins can cause anaphylaxis or severe angioedema-like reactions. So history is most important. Whenever you are starting antibiotic for the first time, you can either go for the skin test where you inject 0.1 ml of the drug intradermally and watch for reaction. Or sometimes you can go for a very low dose like 0.1 ml intravenously and watch for some signs, because you don't want to give full dose and then expect a reaction. You can observe for some time and then you can consider. While giving any antibiotic, especially beta-lactams and penicillins, anaphylaxis can happen, and you have to be prepared for anaphylaxis. Without preparation, you should never administer a drug. Even simple levofloxacin has caused anaphylaxis, oral levofloxacin. So be careful with all the drugs. You have to be prepared for anaphylaxis. Sometimes even false negative tests are there. The skin test is negative, but patient may develop a reaction with the full dose. So still you have to be very, very careful.
Yes, even I faced one very severe reaction with ceftriaxone. With just one injection of ceftriaxone, my patient landed up in severe hypotension and AKI. So I was struggling to save that patient for 3 days. So yeah. I think it is very important.
And most importantly, anaphylaxis, many people tend to treat with efcorlin and dexamethasone, which is wrong. Anaphylaxis needs adrenaline that has to be used. Don't be afraid of using adrenaline when patient is in anaphylactic shock.
Madam, one of the safe ways of doing what Dr. Malani said is to actually give every drug as a 100 ml infusion intravenously. So that you start the infusion with few drops per minute for the first 5 to 10 minutes and then continue it over the next hour. In fact, many drugs like carbapenem are actually given over 3 hours infusion. So, but a safer way is that no matter how small the drug is, if you just put that into 100 ml of saline and give it as a few drops per minute for the first few minutes, you will come to know how things are. And that's the easiest way. Otherwise, you do an intradermal test and you wait for 5-10 minutes and then use it.
My next question is to Dr. Patki. Usually, quinolones are not indicated in pediatric age, but many doctors are prescribing quinolones in pediatric patients. What is your opinion on this? Dr. Patki?
He is muted, I think.
I think we can take the next question till he arrives.
Okay. I think most of the questions are now over. So even we had considered what were the questions, queries taken in the chat box. So, Dr. Patki?
Yes,
can I repeat the question?
Yes, please.
Usually, quinolones are contraindicated in pediatric age, but many of them are prescribing quinolones in children. What is your opinion about it?
It was previously treated because and considered to be causing cartilage damage, but it's now majority of the studies have been proven that it can be used. But for enteric fever and all that, majority of the time, azithromycin 15 milligram per kg for 7 days can be given in a safely than the quinolones. If you feel it is the only drug which has to be given, like for neonatal sepsis and all, if it is required, like this only gram-negative bacilli is only sensitive to quinolones, you can give it. Otherwise, if it is needed, you can give it. Is quite safe. Now studies have shown that it has been quite safe.
Okay. I think most of the questions are addressed, and we conclude this meeting today. Let me hand over the charge to Dr. Suhas Joshi.
Good afternoon, all. Back to basics of clinical features, diagnosis, supported by microbiology, and antibiotic stewardship will be the two take-home messages out of all the lectures which I have heard since morning. Myself, Dr. Suhas Joshi, Secretary IMA Sangli, is here to express gratitude, the vote of thanks for today's session on behalf of IMA Sangli. First, we would like to thank Dr. Rahul Pandit sir for sparing his valuable time through his much busy schedule. His words of wisdom in the management of critical patients with respect with the antimicrobial use are definitely useful for our certain ICU practices as well as day-to-day clinical practices as well as, because his focuses on like UTI, whether it is due to your catheter or central line, that specific and to the point diagnosis of the source of infection makes us much more competent for choice of antibiotic, and narrowness of the antibiotic should be done. Sir, your lecture was definitely very good thought processing and to the point diagnosis and treatment. We are thankful to you for your timely support for us, kind cooperation in your busy schedule, and we expect your support to IMA Sangli for such academic courses in future time. Thank you, sir.
Thank you, sir.
Secondly,
Thank you
we
very much.
are thankful to Dr. Jyoti Chidgupkar madam for her deliberation on microbiology as the basis of antimicrobial use. This talk was much informative for all of us and has taken us to second MBBS microbiology basics, which were brushed up by madam again. Thank you, madam, for your valuable support and very good deliberation. We express our gratitude towards Dr. Vinayak Patki sir for his detailed speech on rational use of antimicrobial in pediatric age group. The topic was excellently elaborated by him. Thank you, sir, for sparing time and guiding us properly for the use of antibiotics in pediatrics, as well as a few comments on adult antibiotic use also. Amongst the faculty members, lastly, I would like to thank Dr. Anand Malani sir for his extensive, elaborative, scientific and methodical oration. His presentation is an eye-opener for many of us. I want to thank him for planning of the scientific program of this CME, as well as being a catalyst between all the speakers and IMA Sangli. Thank you, sir, for your kind deliberation. Friends, without participation of delegates, any of the CME is not possible. I want to thank all the delegates who have registered on Zoom as well as on YouTube platform. Thank you, all of you, for huge participation. Next, I would like to thank our expert panelist team, which includes Dr. Mrs. Palange madam and Dr. Mrs. Geetanjali Gupte madam for their very good MOC today. So also thankful for their valuable inputs and fine touches in panel discussion as well as overall CME program. In spite of busy schedule, all the faculty and panelist members have given their quality time for all of us. Thank you again. I am thankful to DigiShield team, especially Mr. Piyush and Vaishalitai, for their valuable support in registration, live streaming, and up to the certificate handover, which will be handed after sanction from MMC on your registered email ID by DigiShield themselves. Without DigiShield technical support, we would not have reached to our spread across the India for this CME. We have got participation from Bangalore, Chennai, Calcutta, Delhi, and near about all the states of India. So thank you, DigiShield, for making us a national CME holder. We would like to thank all the support staff of all the speakers, hospitals, and our own IMA, Bapu Rajput. Lastly, I would like to thank IMA Sangli Executive Committee and our own President, Dr. Mrs. Madhavi Patwardhan Madam, for her initiative, planning, and constant support to all of us for this grand CME. It was her dream to make this event a grand success. We were expecting around 600 participation, but due to DigiShield and the renowned faculty what we have got today, Pandit sir, Malani sir, Chidgupkar madam, Patki sir, and 2 panelists. This has reached to near about 1300 doctors through DigiShield platform. I would like to thank all of them for their valuable time and support to IMA Sangli. The video recording of this CME will be available on IMA Sangli academic channel on YouTube next week. Thanks a lot again to all of you and the all delegates for participating in this CME. Thank you.
Thank you very much, Sangli IMA and President Madam, as well as Secretary Sir, both the anchors and all the panelists. Thank you very much on behalf of IMA also again, IMA State also. Thank you very much.
Thank you everyone.
Thank you.
Thank you.
Dr. Malani.
Thank you.
Thank you, Dr. Pandit. Thank you, Dr. Vinayak Patki. It was excellent. All the talks were excellent. The panel discussion was very lively, and we had inputs from everybody. And since so many people have asked questions, so they have taken a lot of interest, and all were answered very well. So thank you very much from the bottom of my heart. I thank all of you.